Colleagues, good morning and very warm welcome to the Board of Directors meeting for the 7th of May 2025. Really delighted to see colleagues in the room from various organisations and our governors, and online too, members of the public, council governors, colleagues, and also colleagues coming in today. So warm welcome to all of you. Just to ensure that we use our time effectively and we are here when we are speaking, can I ask all my colleagues in the room to lead into their microphones? I shall be doing so intermittently to make sure that I am heard, just so that colleagues who want to remember what the board meeting in their own time could be confident this morning, they can do so comfortably in their home with a cup of tea or your coffee, but be able to hear us and appreciate the thing today. Just to let everyone know that we have a full agenda, which will finish until part 1 at 2:15. We do intend to take a 30-minute break around about 12:30, and we'll reconvene at 12:55. Just to ensure that as we progress through the day and we have presenters who will be speaking to their papers, if you could be brief and speak to those things which are really important to highlight, and then we'll go into discussion. I understand that all my colleagues have read all their papers diligently, so we don't need to go into some of the detail, but just really focus on the first podcast in this meeting. There will be a fire alarm. It's a routine fire alarm every Wednesday. Of course, if it's going to be a serious one, I will alert you and we shall follow necessary protocol to make your review. So we now move on to the colleague story, and I'm delighted to welcome Siobhan Conway, the Leadership and Management Apprenticeship Lead, and Reece Doonan, who is also team lead on the Acute Research and Delivery team. Is that correct? And you're here today to tell us about your wonderful experience, bring us some insight into what you have learned, what you have understood from that experience, and how we're embracing the learning that you'll share with us into our thinking going forward as we discuss the papers today in terms of the colleague context. So, very warm welcome to both of you. Katie, would you like to introduce them, please?
Thank you, Chair. I think you've covered it all adequately. Siobhan and Reece are going to have a very helpful conversation with us. Siobhan will just outline apprenticeships generally and the particular apprenticeship, and then most importantly, we'll hear about Reece's experience and what he's learned. So I will stop so that we can focus on the people who are really important here. Thank you.
Thank you, Chair. Thank you, Gertie. Just to introduce myself, so I'm Siobhan Conway, so I'm the lead for the Leadership and Management Apprenticeships at the NCA. And we do provide kind of an internal delivery of apprenticeships, of one of which is the apprenticeship that Reece has been on, which is the Frontline Leader Apprenticeship. It is a level 3 16-month apprenticeship, and at the end of that, the apprentices come out of that qualification with an apprenticeship in team leading. It is targeted at our frontline leaders, so typically our leaders that are bands 4 to 6, but not exclusively, so anybody can join that. So I'll hand over to Reece, who has been on the programme for the past kind of year and is approaching his endpoint assessment. So Reece, back to you.
Just wanted to say thank you for inviting me to speak. I'm really excited to share with you my journey essentially through the apprenticeship and what this has meant for me, and hopefully if you've got any questions at the end, I'm happy to be quizzed, but hopefully I'll be able to cover some of it. So why did I select the Frontline Leader Apprenticeship? Actually, I didn't. I was very lucky that I have a very supportive manager who has previously done the Frontline Leader Apprenticeship as well, and actually kind of almost, if you wanted to say, talent spotted within me, within my role. I'm a very new leader within the organisation. I was, before starting the apprenticeship, 12 months into being the team lead, no prior formal qualification of any leadership and management, kind of technically what happens within nursing. And my manager was very much, I think you would really benefit from this course. I think you've got potential to be a great leader and you're trying to do everything that you can within the limitations of your own knowledge. I really think you should do it. So we ummed and ahed, and I was a bit like, how do I learn and work at the same time? And it was all a little bit, I'm not going to be able to get the time. However, the apprenticeship provided that safe time for me to be a learner whilst also working. So again, it was that conversation with my line manager at the time that I would have a protected day a week to be in the apprenticeship. It wasn't labour intensive at all. Obviously, it takes a bit of courage from you to be a bit diligent with time, and I really enjoyed all of the content of the course. So my initial thoughts was that I was quite excited actually. Working clinically day to day, diaries get filled with meetings, and obviously the line management directly of staff, that actually I was going to be a learner again whilst also working, which was really exciting. And I didn't know that this was kind of available to me. I met with Siobhan and the team for the apprenticeship, and it then started to really become really exciting. The first session started, and I was a bit like, oh, lots of light bulb moments happened in terms of I was already trying to do some of the theory, but not really understanding the knowledge behind what I was doing. So it really helped in terms of those as a line manager, those challenging conversations with staff can be really difficult at times. And how do you appropriately empathy support that member of staff? And if you haven't really had much of the formal qualification, I go on my past experience as a staff member with my line manager using those kind of ways of working. However, the apprenticeship provided me with almost, it might be a little bit cheesy to say, but an invisible tool belt of resources that I could pull from. So for me, I was then able to use something called the CDAR template, which is a challenging conversation template, which I could prepare before I had a challenging conversation. So actually, it's now much more effective, and we have actually achieved something rather than a sit down, let's talk about it, not sure where we're going, and kind of let's leave that there. This almost provided a tool work, a framework of being able to get through a challenging time. So I've been on the apprenticeship for about just over 12 months, and the way that the programme works is every month we have a teaching session, and that can range from being in person or online. And my group was luckily around 20 to 25 members of staff, all from varying roles and responsibilities across the organisation. And like Siobhan said, it was targeted between bands 4 and 6 leaders within the organisation. However, I'm a band 7 team lead for the acute research team. And that didn't put me off because, again, having no prior formal qualification of any leadership or management, I knew that there was a knowledge gap to be filled, and this provided that for me. And I am internally grateful for this opportunity and would strongly encourage that this continues. Attending the Accelerated Leader Development Programme was just a nugget of information, and this apprenticeship has really started to embed how I lead as a leader in the organisation, but also how I coach and drive forward and mentorship my staff. So it's been really, really exciting, and I just wanted to end on a thanks, really. One, thank you for the opportunity. I really am excited for the future, but also as I've been given this opportunity from my line manager, I feel now very comfortable to almost help spot somebody in my team to say, come on, I think you can go through this. I want to coach you through this programme, so that actually, when it comes to it, no one stays in the role forever. I am going to move on at some point, and that's, not a scary thing. This is natural progression. So I want to succession plan for my next team lead that they feel confident to step up to the plate when the time comes. So genuinely thank you. And hopefully I've shared a little bit of how much it has meant to me and how I've really professionally grown. So yes, the apprenticeship may have ended. What's the next steps? Where does it end in nursing? There's never a day where you don't learn, and that will continuously continue. And it actually has provided me opportunities to forge a bit more of a career pathway for me. So I would like to go on to a clinical academic career. That's really started to build the foundation blocks for me to progress that way. So, yeah, I'm going to end on that, but genuinely a thank you. And hopefully you can continue to support other leaders or emerging leaders within the organisation at this apprenticeship.
So at least when I came to introduce myself to you, I could feel the excitement and the motivation, and I knew that you would be an excellent presenter for your model programme. And what you shared with us just means when you talk about it, your experience, what you learned, what you unlearned, fact that you understood what it means to have difficult conversations. That's actually very intense and very difficult. And when you begin to learn how to do that better, sometimes you do it better, but you still feel bad because it's difficult, isn't it? But you just demonstrating how you that was very touching and inspiring to me. And I'm sure everyone in this room was inspired and touched by what you said quite profoundly. And we wish you all the best going forward. I'm going to ask whether there are any comments from colleagues, but if not, sounds like summarise. Any comments?
Yeah, thank you. Actually, can I say thank you to you too, because what you talked about was coaching and mentoring, and actually the acquisition of any knowledge through learning and the opportunity to engage in learning is kind of singular unless people commit to, once they've acquired that knowledge and skill set, in sharing that. And we can do that through coaching and mentorship. So I want to say thank you to you, because actually embracing that part of it and ensuring that actually you're spreading that knowledge and expertise amongst your team and championing it is really about, it doesn't become a singular impact of a programme, because actually you're spreading it with others. So, and I'm sure in a clinical academic career, you'll understand that importance of spreading knowledge and the wealth of that. So thank you.
Thank you.
Thank you, Chair. So first of all, I want to again thank you both for everything that you've done in that space. And Rhys, really the energy that you bring to this is fantastic. It's really great to see our leaders being so enthusiastic about their leadership progression. I'm sure that that will be infectious to the people around you. So well done on that. Would highly encourage you to focus on the clinical academic side of things. I think it's an area where we absolutely want to be supporting our multi-professional teams to be focusing. So good luck with that. One question, I guess, probably to you, Siobhan, maybe a quick comment for us as a board in terms of where we are with our apprenticeship programme and whether we are at this stage successful in fully utilising our apprenticeship levy, or whether we have a little bit of a ways to go.
Thank you for that. I think we are working hard to utilise that apprenticeship levy, and we're looking for opportunities to be able to bring in other programmes. So I think that work is ongoing. And I think definitely the frontline leader is kind of shone a light into how we can do that a little bit more, I think. So definitely something that we're working on to you too.
Thank you. And a brief apology, because I should have introduced myself. I haven't met two of you before. I'm the Chief Medical Officer. Very nice to meet you.
Thank you.
Thank you. Big comment, please.
I'm just blown away by what you've said. I'm an absolute passionate supporter of apprenticeships and have been all my career. I'm a non-exec director and my background's HR and people in workforce. And just listening to what you've had to say, as Fig said, it's infectious. It's been a fantastic start to taking the energy right up from the beginning, so everyone else who's after you's got a hard act to follow. But well done, Siobhan, for talent spotting, and well done for realising that you two should do that now, and for you both to continue to talk to your peers as well as the people you would be encouraging to do apprenticeships, because the frontline leader bit is just so big an opportunity to encourage lots of people. And if you're willing to be filmed or just capture that energy, I think we can tell so many more people about the opportunity, because you can't get out there in front of everybody. But if you could get out in front of a few more people, then wow, I just think we could encourage more people. And if we can't spend all our apprenticeship levy internally, I know we donate and encourage smaller organisations, and maybe even learning from what we've done internally would encourage other organisations to think about NCA as a future employer. So thank you so much, both of you and the team.
Thank you.
Thank you. And yeah, just to touch on, I'm happy to be involved, and I'm glad it's coming across as infectious, because I genuinely have really enjoyed it. And if I can share that with anybody else, I would encourage, I know there are other leaders that I've spoken to in the organisation that have the same view that I had of how do I work and learn at the same time, and actually starting those conversations up that it's beneficial for you. Let's take the jump and do it, and then encourage other people to move forward with that. So I'm happy to be involved in any way I can.
That's great. So thank you, colleagues. I did say there would be many questions, at least. I hope you found the feedback helpful and constructive. But I would like to ask to Siobhan, how are we ensuring that we're capturing not only the story, but the progression? So watching Reece on his journey, how will he further benefit? And then you have aspirations to do that too, going back to the clinical world, which is great. But I think we need to report that back on some of those really tangible, measurable outcomes. That's the whole purpose, isn't it? People making informed choice about what they do now, but what they may want to do in the future. And you certainly inspired us with so many different ways around that. The final thing I'll say is learning happens every day. But when you go through a program which structures how that learning can be shaped and informed in different contexts, that's the buzz, because you make it relatable to a particular theory or a particular something gives you line of sight about, okay, I do this regularly, but I didn't know it's referred to as that. Okay, other people feel the same way when I'm going through this journey. So those things are learning that strengthens what you already know from your lived experience, enables you to then share that about thinking when you describe what you've been on for your own journey too. So thank you very much indeed for setting the tone of the board meeting, and it's been lovely to meet you and wish you all the best going forward. Thank you, Siobhan. Thank you.
Thank you for your time.
So colleagues, we now move to the full part of the agenda around apologies. Apologies received from Chris Harrison, our Executive Director, Sue Lorna, our Executive Director, Lorna, our Chief Digital Information Officer, currently studying by FD Nikki Hancock, and also Head of Board, Chief Nursing Officer, who will be represented by Juliet Cosgrove, Deputy Chief Nurse Interim, Joel, deputised very effectively for her. On the call on stream with us is Aziz Rashid and our Executive Director Mitchell Jones, who are joining us online and space in the speaker. So welcome to both of you. May I ask, are there any declarations of interest on any items that we're going to be discussing today? No, thank you very much. Minutes of the previous meeting held on the 2nd of April 2025. May I receive confirmation, but otherwise that they are a true, accurate record of our meeting. What are the next points one we have to make? Yes.
Thank you, Chair. Just a small point of accuracy on section 12, which is page 6 of 11. The second paragraph refers to me as the Chief People and Information Officer. I'm sure Nikki would be rather worried if I was doing some of the digital.
Thank you very much. Any further clarification? No, so we'll accept those as an accurate record of the meeting. Thank you. Agenda item 6. Are there any other matters arising that are not listed for the board members with the raised? Just dotting all eyes up. So, okay. In terms of the action tracker, agenda item number 7, this is provided for review for the board. Are there any questions that colleagues would like to raise? Are you confident that the information presented is accurate for this moment in time? Yes, thank you very much indeed. We move then on to agenda item 8, Chief Executive Presence Gathering Report.
Thank you, again, just in spirit of what you said in the meeting, assume that the report was read. Just some highlights from me, just in terms of the Flex Lab X installation. Again, just wanted to highlight this cutting edge laboratory information that we've got there, and the difference it's making, not just to service users, patients, but colleagues, and how colleagues feel as well about their ability to affect patient care. Also highlighting and getting right first time, again, something that I talk a little bit about in one of my weekly messages, and some interesting response from colleagues as well. But the fact that we're making progress in that, particularly new areas such as corporate theatres and ophthalmology. Again, signalling the board to the CQP rating for Oldham Hospital. Overall, required improvement, but I think it's worth recognising that in a couple of the 5 domains, we've moved to good in respect of that. So in direction of travel terms, that is positive. Again, we'll be talking about the financial position moving forward, but again, just confirming that we have accepted the challenge of 87.9 million deficit against our budget of just under 2 billion and the CIP target on that of around 110 million. Again, we'll be talking about that in the board meeting. And then a couple of other points, just quickly going to highlight the appointment of Dr. Yvette Owen in terms of leading the review into the overall care provided by the spinal consultant. I think that's quite a significant development. Dr. Owen is a highly competent person, certainly somebody I've worked with in the past, and I think she'll be a good steward for this process, but it is an NHS England process that ourselves, MFT and Aspire are contributing towards. And just a reminder about International Nurses Day, which it coincides with Florence Nightingale's birthday. I don't know if anybody knows Florence, but certainly one known character in that history of nursing care. And at that point, Chair, I'll take any questions that colleagues have got.
Thank you very much. Are there any questions? Jeff, please.
Thanks, Chair. Two questions. In respect of the CQC rating for older, can we have an update on the action plan to respond to the warning notice on patient flow and corridor care? Where is that being overseen in our governance, and is there a timescale for that action plan? And my second question was relating to the independent review into spinal surgery. Do we expect that process to affect the work of the Green Oversight Group at all?
Okay, so in the first question, that, if you recall, Jeff, that response in terms of the CQC sits within the My Next Patient piece of work, and that is actually being overseen by the Policy Performance Committee in terms of governance, terms of progress on that. Juliet can provide some more detail on that if you want to know specifics, but there is an underlying action plan obviously that sits with that, and that is being progressed. And obviously the QPC that will filter its way back to the board in terms of understanding progress. I will say that is a complex and broad programme, and I think QPC will need to make sure that there are specific elements of that we pay attention to make sure that we're not just always looking at a broad overview and missing the points of some of the individual components of that. So I'll leave Juliet to add any more to that. And then I'll let Juliet add, and then I'll please.
Yeah, sorry, I think we have been bringing regular updates to QPC, and we did bring an update to board on My Next Patient. I think what's the CQC inspectors did come in to Oldham site last week, specifically to talk about management of patients in escalation areas and specifically the My Next Patient policy, and they were satisfied with what they saw. It cleared up some areas for them, satisfied that staff knew what was expected of them and were focusing on maintaining patient safety. So whilst we have made progress to satisfy the CQC through an inspection, and they're just considering at what point they'll lift that warning notice, because that's still in place at the moment, but it's not referred to on the website, I don't believe. So they'll get back to us when they'll with the process for lifting that notice off. But I think, as Owen said, the main point is how are we safely managing patients in escalation areas. So that's the thing we need to keep broad sight off, even though we'll deal with the action plan specifically related to that warning notice.
Can I just add, I mean, that has to be the focus, because the temporary escalation cases are temporary, and if they're not the right order, the case to look after our patients. So within the narrative, it is about making sure that we provide quality care, safety care, but in the right place for everyone. So I'm sure one of these exactly that's update.
And Chair, can we see respect with Virgin from probably like it's the interface of Greece work led by NHS and how piece of work, and again, repeat, may want to comment on that. So it's a piece of work that we're trying to really make sure that first of all, the two pieces of work are complementary and that they're not fighting against one another. But as you recall, the NHS single piece of work was driven by saying patient who sitting in the being on site, but work through with the involvement of their partners, so on and so forth, to work that through with NHS England. I think the thing that I would just say here, and again, if you can confirm this, I think we're pretty clear about where the overlap issues are, and where we've got commonality. And if there are any areas of difference that may come from where Dr. O chooses to take a piece of work, we'll of course make sure that that is fed through into the Green Oversight Group. But again, I'm just making the point that we've got patient representatives who are part of both the NHS England piece of work and the Green Oversight Group. So whether that be through executive colleagues or through patients, there's going to be a lot of interlocking pieces of work around that. So I think that can move from being reassured to being assured that there will be that connectivity working through. I quite like the fact that it's still a dimension because it's a further scrutiny lens, which I see as opportunistic. I think it's a good thing that we've got those lenses. The only thing we just need to reflect on is that in this piece of work, there is only one patient group arising from one organisation. And it was just interesting to know whether the MFT piece and also the spine piece, as to whether there are any patient groups that emerge from that are not known to the group that we're working with. That could be a possibility. So as this piece of work gets more traction, gets more publicity, I think we just got to be thinking about if that emerging, what happens? Does it create the creation of this consolidated patient group if that happens, or are there potentially 3 separate patient groups based on organisation? That's just one thing in the back of my mind you should have to be on alert to or on that feed on. I don't know if there's anything else you need to add.
Thanks, thank you, Chair. So just a couple of things I would add to say. I think the review has taken a very reasonable approach, because when we first had discussions about reviews, it was unclear what the approach would be, and to emphasise that the first stage of the review is essentially to look at what's happened so far, including all the work that we've done in the organisation that has come through this board, patient safety look back review and the Green report. I think as an organisation, we have confidence that we've approached this with openness and rigour. And anything that comes out of the review in terms of additional learning, I think we welcome that. We will continue with the Green Oversight Group to ensure that we are closing the actions that fall out of Green. And whenever it is that the review and Dr. Ode reach out to us in terms of what they need, I think it is important that we have some output that is clear from the Green Oversight Group that essentially shows that we're more or less on track to close things, or have closed most of the things that we said we would do. And I want to remind the board that we had always said that the Green Oversight Group would be a time-limited group, so I would see it over the coming period coming to a close as we have assurance that we are on track with the things that we said we would do, and that they're embedded within the organisation. And the final thing I would say is just a reminder, again, Owen's all cut the patient group who are very well engaged both with the Green Oversight Group and wider. And we are going to meet with them in their space this weekend to do a little bit more sort of shared discussion and learning and openness to try and continue to build additional trust. And I think it's significant also to note that colleagues from MFT and Aspire will be joining us at that meeting to essentially make ourselves available to the patient group. I think that's very good.
Now, I think that's the first, isn't it? That the organisation will be together with the group, so that's quite an important step. I think just it might be thought process that said, well, if the Green Oversight Group is a concluding point, I think when might that be? I think what I would say, that's likely to be probably next calendar year. And I say that because we know that there's a colonial process associated with the piece of work, which has a kind of a loop time date of colonial process can shift in time for November this year. And again, depending on how long that colonial process is. So that's what I would say. It's unlikely that this work will close certainly this calendar year. It potentially will be next year. We'll be getting back the language close. because for a lot of earth use sort of, quite frankly, it'll never close. So I'm probably to the procedural thoughts and that's where this will go next. Would that help, Chair?
Yeah, through you, Chair. It all helps. I would simply emphasise the point about ourselves, MFT Inspire, talk to each other more, because from a patient point of view, this isn't about us. It's about them and the health service having made mistakes. And the more we keep this about us, it seems like an organisational defensive response. No, it's not. That's why I think we need to be talking more to MFT and if there are patient groups associated with those organisations, should plan that out and offer to facilitate joining. Thank you.
Yeah, can I just emphasise that point? Because you mentioned that eventually the recommendations from the green website would have been implemented. The really that you noticed from those recommendations and how that is instilled within NCA is very important. And we align that with what our patients want to tell us. They want to know that we are safe now, and I don't want to hear that later. So how do we communicate that regularly, not at different stages? There's something to be done within that triangle relationship with that, so that's important. But there's always something we can do slowly when we are upstream, rather than just waiting for the recommendations when the audit report comes back, which could be a long time. And I think that's really harnessed a little bit more robustly going forward. So I hear what you're saying, but that absolutely all we can do around embedding the patient goals, demonstrating our final report or interim report, we can to close off the list of this action, please to get on some of that, or what happens next, what's how and within the time scale. So thank you for that. Did you want to come?
If you don't mind, Chair, yes. So first of all, on that point, I think really important to sort of keep that in mind. The patient group representatives are an integral part of the Green Oversight Group, so we are ensuring that they are involved. I think there's been a bit of learning there as well to recognise that people who might not be fully familiar with the formality of a board committee need a little bit of time to submit in. So I think we're encouraging them to continuously be challenging to us. And certainly Jeff brings that challenge and that lens as well. So I'm confident that they are involved from that perspective. They will be involved in the development of any final reports in terms of the activity of the group. And the engagement that we're doing with them this weekend in their space is an intentional step to ensure that some of them who aren't represented and who also might not feel comfortable being in the hospital environment where some of the historical experiences they have access and engagement with us. And colleagues will recall that I think at the last board meeting we had a brief discussion also about bringing in an independent expert to help bridge that trust gap which we're working on. So just want to assure you on that bit. And just to Jeff's question, I also want to assure the board that we are constantly in touch with colleagues from MFT and the Spire, ensuring that we are supporting each other and learning from each other. And I have a meeting with them this week ahead of the patient meeting as well.
I have one question on that is what support are we offering to our colleagues who are working with the Spire?
Yeah, so that's a really good point. We have, as part of, some of it sits under the green plan, but again, a reminder to the board, there are multiple bits to what we're doing in the spinal space. Some of it sits in the action plan that came out of the Spinal Patient Safety Look Back Review. We have a culture review that has looked into where things are with spines now, that I think is just being finalised now, actually. And following from that, we are scheduling some meetings open to all colleagues within the spinal service to discuss the findings, hear from them what their experience is now. And on top of that, there's also some additional engagement that will happen with impacted colleagues who were here historically, and some additional governance support, including GERF reviews to ensure that we're giving them the right support and that we have confidence that the service will continue to be on the right trajectory.
Thank you.
Just to give an example, I met with a colleague this morning on that, so this is ongoing. And also just add to some activities that we are in the process of commissioning Get It Right first final review of spinal services, which I see as a support of action to colleagues in the spinal service.
Thank you. So thank you, colleagues. We know the Chief Executive's report. Agenda item 9, the Integrated Performance Report. Jude, we are in your hands.
Thank you. So a couple of things to pull out this month. And, you know, the framing of the IPR is to be read in conjunction with some of the AAAs from the subcommittees to ensure we're focusing on the right things. But some positive movement in our people being in work and healthy in month, although in a rolling programme still behind where we set our ambition to be. There is an opportunity, I think, as we launch our annual plan for the year and certainly our annual plan objectives to focus on our My Time conversations and think about how do we cascade from the board agreed plan right through the organisation. So I think an opportunity, particularly in Q1, to give the My Time conversation some focus, but some good work, as you can see, clearly happening in E&F in both of those areas. If I canter through then to the operational targets, the My Recovery Plan continues to make progress focusing on those productivity metrics that are described in the board scorecard and working with the Gove national team to align those to model health system productivity metrics. I want to give a shout out really about our cancer performance. So this is cancer performance lags in the IPR from what we know is the validated position. But I am pleased to report that this week we have confirmed the delivery of all of the cancer metrics for the organisation, both on 62 days, which we've achieved over the 70% ask, on the 31 days, on faster diagnosis standard, and on the 63-day backlog. And I think that is a phenomenal achievement, actually. And I want to give a big shout out to Liez, our cancer manager, and Jenna Slough, who's the support manager. They have worked tirelessly to really do validation of those cancer pathways and track those waiting times through. And also thanks to Greater Manchester Cancer and Lisa Gallagher-Dawson, who has really supported us both financially as well over this last year, particularly in dermatology when we have struggled to get the funding for some of the closure of services across Greater Manchester, and GM Cancer have stepped into that space. So that our cancer performance absolutely helps get Greater Manchester over the line, to be a big component of that. On UVC, we've got work to do. As you can see on 4 hours, we do actually continue to improve. So it's showing some special cause improvement. It's, albeit it's slow, and it falls below where we need to be. So continued focus for us, I think, particularly over this first quarter of the year, and focusing on getting the work that we did on ambulance conveyancing over the line and up and operational, because it will help on the ambulance handovers and should help with the 12-hour waits in the emergency departments. And the work that we talked to Finance Committee about, our length of stay variation and our long length of stay, again, will help with that flow out of the emergency department. I won't say much about the finances because I know Suzanne will pick it up in her report. But just a point on the quality metrics, when we had the executive conversation about Q&P, we discussed actually this IPR would benefit probably from some target setting around some of these quality metrics, because they bob along, and actually what we're not really clear about is, are the actions that we're doing delivering where we set our ambitions in year? So I think we have to focus on that, and we have to focus on improving the quality dashboard that goes to Quality and Performance Committee with some of those targets, and it'll help us understand where we've got common cause variation or where we're trying to deliver on an ambition. And I think for us, that might link to areas of pressure ulcers and infections in particular. And there's probably something as we step into next year when we're looking at incidents with harm, and particularly those with moderate harm, severe harm associated with them, where there are repeat incidents of those, because I think that will talk to our learning. So I think there's, we talked in Q&P, the exec Q&P, there's more work for us to do, I think, on some of these quality metrics to help us understand as we step into the financial environment that we're about to step into this year, that we've got a line of sight for safety and quality. I'll pause then.
Thank you, Jim. Maria, please. And then
Thank you, Chair. I know I've said this before, but I'll say it again because I like it very much. But equally as well, I think we have so many conversations around getting the right information, getting it in the right way to give us assurance. We have that at committees. We had that similar conversation at the Council of Governors meeting. So it's really great that we start with this integrated report, and that focuses us on the areas of criticality. So I really like it. Start there to ensure that we are clear on not causing harm. I also like Owen's report. I think it gives us kind of lots of critical things that we need to focus on. So thank you very much. It's also great to see improving trends across the board. We've not hit the targets yet on a number of things, but I think the trends are going in the right direction. Not seeing that at least in many of the other occasions. So it's great to see that. And as you say, there's targets to improve. I think I wanted to report the trends look like they're all going up in most of the areas. But of course, as an ask, I think it's good that we take in the areas where we still have gaps and focus on those in the communities. So I think in the perinatal report, that's quite clear on how they're doing that. It's not very clear on the other areas. I think it's be good that we can take that similar approach and make sure that whatever we're not hitting the targets on, there's focus in the committees, and that gives us assurance that we're focusing on the right things. So.
Thank you, Maria. Julie.
Thank you, Chair. I just want to agree with what Jude said, particularly around infection prevention and control. I think whilst we are seeing some healthcare acquired organisms heading in the right direction, I think we've also got some indicators. We've got some areas to focus on, and I think with the wider community, with, for example, things like measles, that our approach to getting the basics right is really critical. So we will be paying increased focus and attention on infection prevention and control, and might make some other measures which give us a little bit of an indicator of how effective our controls are, as well as just monitoring the consequence. Yeah.
Thank you, Julie. Jack, please.
Thank you, Chair. Point about timescales for some of the work to improve the dashboard. That's a second point about health inequalities. On the timescales, it's good to hear that there is now work to develop the targets for some of these measures. But I'd be grateful for some indication of when during the year you start to see those targets appearing in the dashboard. And that reminds me of the commitment we've had. The Quality Performance Committee will look at establishing some performance data for community health services. And again, look for some timescales around that. When can we expect to see that developed to a point where we can get some information at board level on what is a massive part of our portfolio, but which doesn't come here in terms of its performance, i.e. community health services. On the point about health inequalities, this arises from my attendance yesterday at the Greater Manchester ICB Health Inequalities Development Programme for executive directors. And yesterday's session was devoted to intelligence and performance information. It was a really helpful session. And one of the many conclusions we reached was that for all the trusts in GM, our integrated performance reports are not integrated with health inequalities data. I think we're an example of that. We've got excellent progress on analysing health inequalities, we saw at our recent development session how we've developed an indices of the qualities. But none of that is being joined up with the performance reports. So we're unable, in my view, to really understand which cohorts in which neighbourhoods are really driving our performance. And this isn't just for me a matter of intelligence, it's a matter of really driving action to improve our performance, particularly on urgent care and waiting lists and waiting times. So, for example, Bolton are doing interesting work analysing missed appointments by ethnicity and by deprivation and by place. And they were doing quite well on missed appointments, and nevertheless, that might hold prospects for us going further on that. One of many other examples, good work by Professor Chris Beattie on avoidable hospitalisation and interrupting the flow of demand. So I just make the point that if we had that integration of health inequalities and intelligence into this report, it might open up for us greater insight to what's driving our performance in communities. Thank you.
Yeah, I'll just respond to those. Thanks, Jeff. So you'll start to see new IPR next month. So as we step into this is sort of the close of the last financial year. So you'll see that. I've spoken to Alex about the community metrics and adult social care, and there might just be a couple of what I would call leading indicators in the first instance for us to start to look at board level, and then Q&P does the work underneath that. Around the more detailed measures. So those will come in the final board scorecard next month. Just in relation to the health inequalities, I mean, we can have a conversation about what we want to see. I can tell you categorically that the DNA rate that you see and the improvement that we've seen this year is driven by a focus on patients from our most deprived populations. That's what's driven the improvement. We've developed an app, we analyse the data with Christine there, who is our Director of Public Health, and we know which patients from which localities are more likely to DNA, and we've put control process in to ensure that we engage with them around their appointments. So, but I think it's the detail that sits beneath what's driving the metric, and is some of that looked at through a lens of inequalities that I think you're describing. So let's pick up where we see that and where we have that conversation that might just sit in some of the narrative as well about, you know, actually why is that improving and where is it improving? But we'll have a conversation. Harmony and Tim.
It was more about me. It's great to know that we've got a new revised IPR coming. I think what we've got now is much improved anyway.
Yeah.
And to see some improvement. My plea would be to try and make some of the information that goes into it a little easier for the public and me to understand. So there are a few slides in here where we still use jargon. For example, the safety slide has a lot of acronyms in it, and if we've got observers for the meeting, they may not understand what those are. And on the urgent and emergency care cancer slide, we have got some information about pathway performance for skin cancer dependent on GM system resilience. I think somebody observing that would go, what does that mean? If this happens, that means yes, and if this happens, that means, and I know we've got QPC, so there is a fine line, but I think it could just do with a little bit more explanation, which would then give more, for me, more assurance.
Some of it is the format of the report. I have to be honest, the teams have a certain word.
Okay.
So I can talk to Alex about that, but they are limited in terms of
some of the slides have a lot of information on them, which I'm not suggesting we add because I think there's enough. And there are some where it looks like there's a lot of space and we could add a bit more in. So thank you.
Tim, please.
Yeah, I kind of just open by saying, yeah, I recognise, and you kind of look back over year ago and beyond. There's real sustained improvement here, so it's to recognise that particularly. And certainly support what Jude has set out about that trajectory of quality metrics, and certainly Jeff's point, I think, really well made around bringing health inequalities as part of this. And also the friends and family test, I think, kind of recognising that as such an important signal. There's sustained improvement there. Just a couple of points. One particular one, Juliette, you kind of have already talked about IPC. It does seem to be a persistent issue that's kind of picked up. You know, even when you're walking around, just the attitude to hand washing, the diligence around that. I'd kind of support a bigger piece, whether we look, you know, it seems ripe for a kind of fresh initiative, you know, around some of the basics of how we implement our policy and the culture. So I'd certainly be supportive of that. Just a general point, and I'm not necessarily looking for an answer today, but the star factors at the end, which kind of talk to our data, I'm kind of still puzzled a little bit about that. For example, on health-acquired infections, every one of them says our audit accuracy is red. So we're looking at the IPR, and then these star factors suggest there are areas where we cannot draw safe conclusions. So it's probably just developing that page, talk about how we're addressing some of the gaps and whether those gaps are ones we should really be worried about. So I just kind of flag that as an area for IPR development. Thank you.
Thank you very much, Jim.
So, just in terms of the infection prevention control, IPC, things, I think the thought around maybe a deeper piece of work. There's still a thing I'm still trying to reconcile, sort of being here, I guess, around uniforms, and particularly colleagues wearing clinical attire. That is not, I think maybe if that's all people have seen, some people may fall into a trap of thinking, well, that's the norm. There are other trusts who have different protocols for uniform and what you wear, and they play into infection prevention control. That's the thing that's something like. The other thing, just reminded of Jim Mackey's letter to us around matters financial, but also therefore asking us to look at safeguarding. The other area he asked us to look at was infection prevention control. So I think going back to what Tim is constantly asking us to think about board appetite and its tolerance around risk, I think there's a conversation that we need to have in respect of that. And therefore, if there are expectations about more focus on infection prevention control, that needs to be potentially considered in the context of less resource than what we've currently got now. Or if we are going to put more resource into that, I think the board just needs to be clear about what's the impact of that. So I'm just going to flag that, Chair, if that's okay, and to say that we need to be having these thoughts no longer in isolation. We need to be triangulating with other things that we need to consider. Thank you.
Thank you.
Yeah, please, if possible. I think the sentiment of those issues around corporate functions for infection prevention control, safeguarding, etc., is a distinction between whose business is it. So the business of infection prevention control and safeguarding is the business of those people who interact with patients and families. So I think it's ensuring that the accountability is sitting where it needs to be. So I think we absolutely take on board your point, Owen, but I do think this is how we move the accountability and responsibility to where it needs to be, and not expect, and then having the right amount of SMEs driving our policies and escalation. But I think that's your point about uniforms, hand hygiene, those sorts of things, and the responsibility of specialists and responsibility.
SME didn't get that.
Master experts, yeah, sorry, yeah.
Thank you. Repeat.
Thank you, Chair. Just a couple of things I'd like to highlight. Obviously, Jude's name sits against the IPR, but I think we need to recognise that this is a collectively owned thing by all of us. So I just want to make it clear that in trying to improve it between Jude and the team, there's a wider responsibility for all of us. And I do recognise that from the team's perspective, actually they could do with a bit more support in terms of the narrative that makes it easier for people to understand. So just recognising that and committing that we'll work on that. IPC has been covered, but I just want to emphasise it is again also Juliet has framed sort of the wider responsibility that we all need to work on. Uniforms are an interesting one because they have come up. I think uniforms are really important, both from an IPC perspective, but also from an identity and pride perspective. And there's probably scope for us to do better in that space and have a targeted piece of work around that. And I think it's important we also don't forget that from an IPC perspective, we do also have some infrastructure challenges that will sometimes be contributing to this. So just worth us to work.
Thank you. Thank you for all those comments and points of clarification. I think it's absolutely clear there are a number of things we need to do, don't we? The IPR is currently developing, it's evolving all the time. What we need to see is that what we share in these board meetings is beginning to be evidence in the progress of the IPR, not only mirroring what we're saying in this meeting, but also mirroring what we know is going outside. And I think the relationship that we have between understanding trends and appreciating the risks that are associated with those trends, that's one element. But having a plan that's in place that we have oversight of, and I know that various committees will have oversight of different things. And I know the Change Portfolio Board also has its lens on performance in many of those areas, the UNC and theatre and outpatient. But I think we do not triangulate. So that it absolutely needs to be done around the triangulation. I think why cost might drive some of these changes, what must all be front and centre is patient experience, patient outcomes, and patient safety. And within that, the quality of care element. The infection prevention control piece is very important. I understand exactly what you said. It's around behaviours, responsibility at individual level. We know that when we're seeing these trends go up and up, it's because there's non-compliance with what the protocols that we have in place. That's really not good enough, is it? Because that is something that we'd expect our colleagues to embrace. So I think we need to be mindful of that, but we also need to be mindful of the point Owen made around our capacity to manage all of these different things, but in the right way. So I feel going forward, we just need to keep the focus on the trend, understand the performance, acknowledge Jude, the team has done incredibly well with our cancer and diagnosis, and with that is a really incredible from where we are and where we're going. But always come back to, do we sustain the improvement? Can we escalate the improvement further? Can we feel confident about it? And that's the space where it's a bit more fluid, and we need more focus and structure around that. So it is important to say Quality Performance Committee and the people in the committee do have line of sight over of people's performance, quality performance, and staff and to the quality of care. But it is a group effort, and I'm so glad that everything you said it. So chief nurse and our chief medical director and our chief of people and also our chief delivery, you are the ones who are leading this in terms of leadership. We want to make sure be confident that the support you have around you is delivering with the same intention and the same impact. So that what we see at board is actually a much more improved report where we can feel more confident going forward. Like, yes, I can absolutely say I'm sure that I have line of sight to do it. I have line of sight of the outcomes against these metrics, but I also appreciate there may be some fluidity because there are some things which are still emerging and we're finding the data to inform that. The final point is around the health and quality piece. We do need some way in which we are reported at board level where we have put in interventions and we have used the metrics which have been an enabler in addressing some of the waiting times. We've done that with the metrics within maternity, and we've also done that within dermatology as well. So we just need to capture that in some form. So to your point, we know it's happening, but we have no report which indicates how it happened and what kind of what's going to happen next using that, how the quality plans. So things we want to take forward, particularly on September. Thank you very much for a very constructive discussion. We move then on to agenda item 10, which is the closing water assurance framework. Tim is going to take us through this. Tim G.
Thanks, Chair. So we asked colleagues to take the report, read the tease out 2 or 3 key points. I think the first point is in line with our policy, water assurance framework, and its content has been reviewed through our relevant subcommittee structure, particularly get to report for closing statement. The paper also refers to the work to establish an opening position for the water assurance framework 25-26, which is due to come back to board in July 2025. In line with our policy, those opening positions will be taken through our subcommittee structure through the remainder of May and into June. And we'll look to consider as part of that work what our risk appetite is, including where we have got tolerance in and around that, and that speaks to, in part speaks to the paper that was taken to audit committee at the back end of last week. The final thing that I'd note, Chair and colleagues, is that our board assurance framework and structure has been subject to internal audit, who did conclude and support the fact that it's got all the constituent parts that you would expect it to see. Their questions.
Thank you very much. So we are we've been on a review of the water assurance framework and we've so reflecting the audit report before 24-25 position. The first of all, are there any questions or points of clarification on that? And then we are asked to note the updates by post month of the 2025 insurance framework. Okay, do you?
Yeah, sorry.
Okay.
It's a reflection. I made the same reflection at senior management team meeting actually.
Yeah.
Is that none of these risks have changed other than planned care. None of these risks have changed over the course of this whole year. So we've had 4 quarters. And actually, so you look at the financial risk with capital, the capital risk says there'll be statutory issues if we don't prioritise our capital plan. Well, we haven't really had statutorily safety issues with our estate in a year. So one assumes that we prioritise the capital plan appropriately to maintain the safety of the estate. You know, the digital programme is designed to tell us where we put the investment. So is the likelihood really a 4, you know, or is it possible? The same about the financial plan. You know, if we've not got a multi-year plan, but we've just signed off another, you know, huge SIP. So I think it's a comment for me. I think also the change portfolio one, it looks like we've just removed it with a risk of 16, but actually the narrative says we've got really good processes in place and therefore the likelihood should be right down at 2, you know, and therefore the risk is so low that it's not now worthy of consideration by the board. But if you look at it in the cold light of day, it looks like it's not really achieved a great deal here in managing the risk to the organisation. A reflection.
Helpful reflection. Tim.
Yeah, I think that's a fair reflection and a fair challenge, and probably speaks to some of the discussion that was held at Audit and Risk Committee last week. I think that the task and the challenge between now and securing an opening position to 25-26 is for colleagues and board as a collective to be more realistic as to what risk we accept in 25-26, given the challenge that we've got to face, and where we start to see a greater tolerance and flex away from that. I think that's where a revised risk appetite statement will support boards to make a greater assessment of those decisions too.
Yeah, and I agree. So we're looking backwards, 24-25, which is close to that. Going forwards, we need to have that both. Thank you.
Yeah, thank you. I don't want to repeat what Tim has just said, but that is absolutely the conversation that we're having Audit and Risk Committee and how we understand the connectivity between closing down a backup issue and reopening a new one and reassessing our risks and understanding where the land lies in all honesty. So I think that's a live conversation. I think it's a maturity of this document going forward, and I think there was an acceptance, wasn't there, at that committee that we need to spend some time understanding that. So I anticipate we'll pick those reflections up, Jude.
So thank you. Rachel?
Thank you, Chair. I think I understand completely where Jude is coming from there. I think Lorna and I are speaking at the moment about the cyber and the digital risk here on the BAF, and I think it's a really positive exercise in my view to reassess on an annual basis, to review and revisit. I guess one area where it could be not as helpful is where we're not thinking about these risks in a more strategic or medium term way. So how do we actually look at them, these risks, to get them to tolerance? And for many of these risks, particularly digital and cyber, that could take 5 years, could take 10 years based on a very long transformation programme. I think I would like to see a little more and have a better understanding of when we feel we get to tolerance with these risks. And actually, if this is just a 12-month, the next 12 months, we're looking at what we can achieve in that time. Are we as a board, do we feel really comfortable with where we're going to be at the end of the next 12 months? And actually, how far from tolerance will we be at that point, rather than it just feeling at times like an annual review without that strategic focus. Thanks, Chair.
Thank you, Rachel.
Yeah, thanks, Rachel. Again, I agree with your comment. I think a lot of it plays to the discussions held at Audit and Risk Committee and the discussions that have been held in and around it, whereby I think in the production of the opening statement and risk appetite statement, we will get to a position where the board assurance framework and risk management in general becomes less transactional, and it's something that becomes more dynamic, more agile, and helps us truly understand the way that we allocate resources across the organisation and take decisions. But that will take a period of time. It isn't a flick of a switch.
No, it isn't, but there's work to be done here, and it isn't entirely responsibility of the board holistically. Non-executive directors can do their work based on information that they receive. So there's some high material here, but who has the focus, who brings that information, how you identify the gaps, and when you've identified the gap, the control are they investment, then you can get hindsight on what comes through this board and that might be. Maria, you can come.
Yeah, just building on Rachel's point, I think there's a target risk date, which I'm assuming is a date when we come back, when we expect to achieve the target. But actually, for a number of those, that's in the past. So we have a few of them where it's March of this year and we've still not hit the target. So I think there's work to do to say we're behind where we need to be. When do we expect to get back to on track? So I think for me, that one is maybe a critical thing to make sure that the dates we put in here are realistic. We're working towards them. If we're seeing things in the past, kind of says we're probably not.
Thank you, Tim.
Make two parts of question to respond to Maria. So I guess the target date would have been as at 31st of March, because this is a reflective piece that concludes at year end. The speak to the comment that you made, Chair, I think the work to get to the position that I'm certainly hearing board talk about around being a lot more realistic around risk, our ability to manage risk, and what we're willing to accept and tolerate. I would absolutely suggest that is the work of colleagues around the table through the subcommittee structure in May and June to get to a position at actualised board where we are comfortable with what it is we are putting forward. I do think it will look different in 25-26 than it has done in previous years for different regions, which we've covered through the discussion.
Thank you.
Can I just check, when do we expect to rebase those dates? The ones that are in the past, because I guess for the digital one, it's quite clear that's another 3 years. That's fine. But the ones that are in the past, I think we need to be taking action, say, when we come back to them.
So the target dates will be revisited as part of the process that runs between now and July through the subcommittee structure. So for the digital ones, they would come back through Research and Innovation Committee or discussion, challenge, and hopefully approval to then be submitted to board as part of an open position statement in July.
Denise, you had your hand up.
Thank you, Rubina. I think that whilst I hear what Jude's saying, I do think that we are discussing these risks dynamically. So, for instance, on People Committee, there was a point where both our risks were about to change. So we had a year where sickness was falling, but we were just at the point where we were about to change the rating, but the strikes were still on. So we just thought, do you know what, in terms of well-being and this, what the staff were doing, we'd wait till the end of the strikes. And then, you know, when the strikes finished, sickness had started going up again. And so we've had this rise in sickness. So and the same with the leadership risk. You know, we loads of people going on ALDP. We were seeing that appraisal rates had gone up from 80 to 87%. We were seeing different changes. But then the clinical leadership model was coming in, and we had a big change in leadership. And so at the point where we were considering perhaps to lower that risk, another thing came in to change it. So I do think that, you know, from my point of view as chair of the People Committee, this is something that we've definitely discussed. You know, we discuss the BAF regularly and have looked at the risks and lowering it. But then, you know, it is dynamic. This is not something that's just still and oh, you know, we've left it the same for the whole year. We've been considering it at every meeting, and things that have come into play to improve the situation, then things came into play that, you know, made us not change that risk. So I just wanted to make the point that, you know, this is a dynamic thing, and as you know, someone who sits on QPC and People Committee, it's something that, you know, things have changed. It's just other things changed too, which meant that the risk level stayed the same. I just thought that was an important point to make.
That's the point well made, and I think we all recognise that in the subcommittees we do review risk. But it goes back to Tim's point of also I absolutely need to make sure that the information and our risk appetite reflects actually what's going on at the time. Review is important. Review itself is dynamic, but I don't really have the infrastructure around our body short training that delivers that confidence about how this risk should be identified in the first place, and whether we should continue with it and how that's kind of reported. So thank you for that, Azim. Very helpful comment.
I was going to say about something very similar to Aziz there, in that we have looked at the risks in the Research and Development Committee, and clearly the digital ones have transferred over. Because it's a quarterly committee, we don't meet until the 25th of July. So for it to come back to July's board meeting, we'd have to do something outside the R&I committee. I don't know how practical that is, but I didn't want us to miss that. Yeah.
Thank you, Colin. Right, so colleagues, maybe we conclude this item in receiving and reviewing the board issuance framework for 2024-25 and noting the updates on proposed developments with 25-26 board issuance framework as described by team and informed by the conversation this morning. Yes, thank you very much indeed. Agenda item number 11 is the finance report. We begin with the report from the finance committee. The team probably very kindly leaves you with Sue London, who has been her apologies on a normal update.
Yeah, just quickly, this is the meeting on finance committee of the 25th of April. Just quickly, there's a couple of alerts. They're not major things, but I'll just refer to them. One related to a small electrical fire at Bury, no evacuation, no harm, and processes operated as they should. Probably just reflecting, the Finance Committee has got a grip over the last few months through the Estate and Facilities Performance Dashboard of greater assurance on fire safety, which was a concern a few months ago. So that kind of ties together. And the other alert relates to just further inquiry relating to a contract being undertaken by one of our hosted services, so the hosted services board, to get a bit more context on that particular issue. In terms of other areas, I mean, the advisor areas, big issues, and but they've been communicated partly today as well through Owen's opening paper, and Suzanne will talk to as well. So obviously it covered the 24-25 achievement of the financial plan and all that goes with that, and also around the annual submission that we briefly talked of. But there's also reference of certainly with the 110 million CIP for the Chief Finance Officer to support on a board development day of kind of how some of those risks we have greater line of sight to the route to 110 million. And an important paper from the Chief Delivery Officer on productivity, which will be a greater focus for the committee. The only final one, I mean, clearly EQIA and QIA processes are ever more important in the period ahead, and certainly a role for every subcommittee, but particularly we're seeing that the Audit and Risk Committee should have a more formal view of those overall arrangements, as well as the work the other committees will do with regard to those. That was it. There's a couple of contract approvals that took place, but that was the work of the committee.
Thank you very much, Tim. Are there any comments or questions for Tim? Thank you very much. So, Joe,
just a quick one. I didn't want us to miss the conversation we had at Finance Committee about the 3-year financial sustainability plan potentially coming to the Finance Committee as well as Change Portfolio Board, given the escalation, the scale of our financial challenge we now face. And alongside that, just a question really, when we will be having the board development session on meeting that financial challenge that Tim referred to. I asked that because in part B of today's agenda, the board a couple of items which are starting to look at some strategic decisions. But then in isolation from us looking at the whole picture. So it'd be good to know when that session is likely to be held. Thanks, Chair.
Second, Jim.
Second, Jim. Thank you, Chair. So can we accept the Finance Committee report as given by Tim and move on to the finance, also finance?
Thank you, Chair. And just to Jeff's point, planning is well underway, Jeff, the development session to give the board real visibility on some of those challenges that we've referred to, and the ASP will also be picked up in that session. It feels like old news when I'm talking about 24-25 now in terms of close down, but it's really important for public record just to recognise where we closed 24-25 in delivering our financial plan in full. And by that I mean delivery of a 4.4 million deficit, which was agreed with the ICB, and is a sort of real achievement, I think, given the context of where we are in the health service. So I just wanted to note that and record that. Within that, there was an element of deficit support as other organisations received through our ICB, and we also met in full our capital plan, which means we spent within the envelope that we were set. So again, another positive result in terms of some of our financial obligations. Within that, and this will be absolutely a place of focus for board conversations going forward, but we did achieve over £90 million worth of cost improvement during the course of 24-25, which is marginally ahead of what we were required to deliver. And importantly, within that, 3/4 of, or 75% of that, was made on a recurrent basis. So £66 million of recurrent efficiencies, which is again marginally above the plan that we had. As part of delivery of that position, we also managed a number of in-year pressures, which when we started the year last year, we didn't plan to have to manage alongside that. So by that I mean the impact of industrial action and some of the payroll pressures. So we absorbed those within that financial position as well. Our cash balances have closed at the end of the year in what I would describe as a reasonably healthy position at 70 million. As I referenced at last month's board, we're going to pay really close attention to cash going forward. It will be a national area of focus, and we will bring that to life through Finance Committee in a little bit more detail. Just wanted to conclude by just saying a huge thank you, because every member of this organisation contributed to deliver the financial position. It's not something that happens in isolation in finance. And the importance of that delivery allows us to moderate as best we can what we're required to deliver into 25-26, which, as the Chief Exec's update has always referred to, will be another challenging year for us, but it puts us in the best place that we can be as we face into 25 and 26. So we're in the midst of our audit close down process as we speak. Touch wood, everything is going well, and that should conclude in the next few weeks. I'll just touch on 25, 26 ever so briefly. So we have signed up to and agreed to a financial plan with the ICB and with the national team in terms of how do we use our £1.9 million to best effect to support everything that's a priority for this organisation. So the importance of that EQIA process, which we've emphasised just recently in the update from Tim, we have agreed that we will have an overarching view of that through Audit Committee, but we are going to hear from our Chief Nurse at Finance Committee next month as well to hear how that feels from a quality perspective too. We've already initiated some conversations into the organisation so that all of our colleagues are well briefed and understand how we work together to support delivery of our financial requirements next year. And we're standing up some engagement sessions in the next couple of weeks so we can have some good conversations and dialogues with how we need to reimagine how we provide services within the 1.9 billion that I referred to. So it's really important that we're working together on this understanding, and we're directing our resources to the most important places. So those conversations are already starting to take place. That's probably all I would call out on 24-25, but obviously I'll have heard board in a few weeks on month one. Very much so. Any questions?
The one that has a significantly big variance is the agency spend. I'm just wondering what's the driver for that and how do we make sure that it doesn't come back in later. So we've got nearly variance of 50% on the agency spend for the year.
So we've made incredible progress in terms of our agency spend reduction. But you're absolutely right. Through conversation Juliet and I have been having very recently to maintain a clear focus on reducing agency spend and also supporting appropriate use of bank spend will continue to be a focus into next year. We've agreed some specific targets about how we might do that. And to really focus on having the right people with the right skills in the right place and not lose sight of the good work that's happened already. There's always a little blip that happens at year end. It happens at year end as we capture all of the expenditure for the end of the year. So sometimes we see a little bit of a peak that happens in March. And as we approach the end of the year, people are taking annual leave that they need to take before the end of the year. So sometimes, again, that has a little bit of an impact on next year, on the end of the year as we close down.
It'd just be good to focus on that. So
we will be. Don't worry. It's absolutely an area of focus.
I think it's really important to acknowledge the last comment you made around that this journey was owned by everyone in the NCAD. So this is just about board doing how the board engaged with our colleagues and saying what is yours work and how can you help, and we need to continue with that and a bank involvement engagement and enabling them to understand where we are and where we hope to be, which will only be achieved by relying the council about why we're making the decisions we are making. I think the QIA and quality inspectors are absolutely key to this, absolutely key, because explaining and illustrating the rationale that some very decisions we're going to having going forward. We've had an extremely difficult, challenging year that we've come through the other end, but when you were living it was a very fragile time. Going forward, it's going to be as difficult, if not more, definitely more. And the more we can do together in one voice and acknowledge what's going well, bring upstream quickly, influence we can't in place or change we can't in place. The ultimate issue that is to it. But at the centre of all of these changes and transformation had to be patient, our carers, our services, and our colleagues who care for them, both inside the NSA and outside of the NSA. That broader piece informs what we do, creates new need, and impact externally and how then our services will be used, and also our work we need to develop in the right way. Suzanne, so I think we captured those points really well. Then move to my colleagues in the board to ask them to receive the financial reports and then the balance as well.
Agreed.
Thank you very much. Okay, agenda item number 12, quality and performance. Tim, you're going to kindly again.
Yeah, it's just very, very briefly, it's just to formally remind ourselves that the QPC meeting in April was stood down, that planned to be stood down, and that's as recorded in the April board minutes, and that was replaced with an exec-led session. So that's just a
That is why we don't record for this meeting. But the meeting, I believe, was used in Gazette to address some governance and assurance of the challenges that we're facing within our policies and patient safety performance. Thank you. So we have a perinatal quality surveillance report. Faith is going to speak to this meeting. I don't think she has arrived.
No, I'm just
Because we are
checking where she is.
If I may, colleagues, I'm going to go on to the next agenda item, if that's okay. That's the learning from experience reports, and Julia, so please speak.
Thank you, Chair. It's a very detailed report, very comprehensive report, actually with multiple authors, so hopefully that gives you some assurance of the significant amount of work going on in relation to learning from incidents and experience. A few things I just wanted to bring forward, but I think most of this is read. There's a significant bit of work in there about our never events, which will focus on nasogastric tubes and theatres, so you'll see the work that's done in relation to those. So hopefully that gives you assurance that we're both identifying where we have never events and putting the appropriate interventions in place to prevent them from happening again. There's some really, really great work around the network events where the QI team are supporting colleagues to share their learning, which I think is excellent and something to credit the team for. Something which isn't actually in here, but I thought it'd be worth throwing out is, because this is a quarterly report, is a piece of work that we've just set up, which we're calling compassionate engagement with patients and families. That's taken us further on from the statutory work we need to do around response to complaints, and also sorry, I'm looking for duty of conduct. So it is about much greater engagement with families and patients about their involvement in investigations around incidents and complaints. So we'll bring you a further update on that at some point, but that, I think that's absolute movement that's in the right place. And then the final thing I just wanted to point out was there's a section in here about Martha's Rule. It just tells you the detail of a very, very tragic incident happened where a young girl was in hospital, and her and her family did know she was deteriorating and didn't have the mechanisms to request that support. And unfortunately, the child died, and her mother is been involved in a significant campaign to ensure that people providing services listen to patients and their families when they think that something's going wrong. And we've had a successful implementation of Martha's Rule at Oldham, which is detailed in there, and there's some missing data, but the data, there were 108 calls at Oldham received by the critical care outreach team, and 4 patients were escalated as a result of that, which is really good. So it shows that the process is working, and as you'd expect, sometimes patients and families do know because they know themselves and can tell you some really important information. So they were the main things that I wanted to bring up in that report. Happy to take any questions.
Are there any questions? Really pleased to see that the triangulation piece is coming alive. When we take the learning, how we use it to invest learning improvements. It's great. Delighted to know that we have taken on Martha's Rule. I think it's something that's, in terms of real transition and change, that is really impact that families experience with their children get wanted to raise and therefore resolve this. So very important we deliver against that. Although we have been sometimes that's not as effective as it should be, but it's not about that. It's about recognising that families are correlated with their loved one and receiving the as we do. very to alert, confidence in the system, 13, 108 for, I think really important is the demonstration. And I do really want to course would be to them. Would be
Very briefly, Charlie wants to add, just to make the board aware that we were one of the pilot sites for a lot of this route. So we put forward a bid and all one of the pilot sites just to participate.
Thank you very much. So we that notes your report and support the implementation of any continuous improvement plans in relation to the small recommendation. Thank you. Next, shall we go to Faith? I know that you're here. Could you just finish the nursing establishment? We'll come back to you. Yes.
Just so again, I'll take the papers. Oh, sorry. I'll take the papers read. Just that it's helpful to understand why the paper's here. So it's a biannual review, and this is to give board both assurance, but also to ensure the board has oversight of nurse staffing levels. This is a critical safety feature of organisations. So I think what you've got here is assurance that we have a process of regular reviews of establishments. You'll see that we're by not asking for investment, we're demonstrating that we have got enough workforce, nursing and midwifery workforce in the organisation. Some of that needs to be slightly moved around, which the directors of nursing are doing. So I do think you are receiving assurance here about nurse establishments and the reviewing the processes. However, I would like to point out towards the end of the paper where we're looking at the risks and the gaps in control around the risk of this, and so it's on page 188 of the pack. So the key gaps in control that are in there are around sickness and absence levels being really high. So despite us setting establishments and getting those reviewed, sickness and absence will fundamentally affect whether or not we've actually got enough workforce in our wards and departments at time. Obviously, where we can use temporary staffing as a way to resolve some of that. And I think we also do some further work around ensuring, across an organisation of this size, that our policies and procedures are always in place, and we are noting that as a small gap in control. So there's some significant work going on around that. So they were the main points I wanted to raise. I'm happy to take any questions. It's quite a lot of detail in there.
Thank you. Are there any questions or comments? Aziz, please,
Thank you, Chair. I noticed on this report something that's never been brought to my attention as or to the attention of the People and Education Committee, and that is that the healthcare support worker sickness rate is 12.28% in Bury, 13.6% in Oldham, 12.6% in Rochdale, and 15.5% in Salford. This is double the average NCA sickness rate. And, normally when we see something like that, that rings alarm bells because there's something going on here. That is very unusual. And there's something wrong here, with that group of workers. And I wondered, is that, are you across that, and what is being done about that? Because that's an enormous level of sickness. And I've never come across that before. I didn't realise that was the case.
Thank you, Aziz. Juliet?
Thank you, Aziz. That's a really helpful question, actually. And we just, as part of our general approach to workforce management, which in including our CIP, because we've actually got a significant CIP target for nursing workforce. One of the areas of focus is sickness absence. So we've got one of our directors of nursing, David Thorpe. He's leading a piece of NCA-wide work looking at sickness absence, nursing, particularly nursing midwifery, but particularly nursing. So those data, so we are scrutinising those data right at this moment in time, Aziz, with David leading that piece of work supported by Gertie's team and the finance team, actually. So we should expect, we're starting to look at what the causes of that are. and making sure we're using the policies and procedures that we've got in place to support people getting back to work. So work in progress, being led at the right level across the organisation, and we'll report that back through to the people committee on that work.
That's a really important point you raised there, and some of it's around how we break down nursing and midwifery staff. Who else is within that team? I think the healthcare system often doesn't come to mind because we're focused on nursing, and we have discussed the point around. But when we talk about nursing establishment, we do believe that it's system, and that's been a long-standing kind of challenge for us because when Faith comes to give her reports over the last year, so we recognise sometimes there's a shift in our capacity to deliver that one-to-one care, and we change the establishment, don't we, when we have 6 outfits and more things. I think it's about chunking down to the right detail and the board having lines down of something incremental, areas of absence that we don't think about, but we should be focused on.
I think so, yeah. And I mean, Joe's been supporting our work on this as well in terms of control of spend. So it's us understanding the data in a much more significant way than we have been. So that work is definitely been driven by the data and benchmarking that data as well, both within the NCA and outside GM and wider. So the piece of work that David's leading is going out to some of the better performing organisations in terms of sickness absence management to understand what they might be doing, which we could learn from.
Very much to you. Suzanne?
Yeah, thank you, Chair, and thank you for the report, Juliet. Just a couple of points from me and then one question. So within the report, it makes reference to investment being required alongside the balancing and rebasing across. It would be helpful just to clarify if that's still an outstanding issue, because we did do some work at budget setting time to address that, but if there's a residual issue, it'd be helpful to understand that and when we need to understand that by, please. Second point, just to echo what you said about the importance of getting the establishments right and to have that absolute clear understanding across the board, because that has an absolutely critical relationship with temporary staff usage. So I really welcome the work and happy to work with you again, on the controls piece, because that will be really important this year. And then the question, the establishment reviews focus on ward staffing, don't they, by nature? That's the framework that we use. I just wondered if there was merit in us potentially looking at something together around the wider nursing spend across the organisation to understand, how we're utilising our nursing staffing and where that variation may sit as well. It's outside the parameters of this, but would there be value in having a closer look at that?
Yeah, so I think it brings in all of the parts, doesn't it, about what we believe safe staffing levels are and how we get to that number, and then understanding total spend. Yeah. And I think there is some variance, and I do think there is definitely opportunities to look at, like I said, best practice within NCA, because there are some good performing areas. But I think possibly we haven't had the level of oversight from a financial perspective into what's the actual spend. So we're not looking at all of the variables when we're looking at what activities we're doing and we're trying to maintain their staffing. And I think the point is we have also got a just short of 7 million CIP target, which we've signed off attached to nursing and midwifery staffing. So all of that does need to be considered in the round as alongside safe staffing and well-being of our people.
Thank you, Julia. Thanks, colleagues. Can we receive the report and the recommendations 2 and 3? Thank you. Dave, we'll come back to you now. That's okay. Welcome. Ready to present your report?
Yes, thank you, Chair. So there are just a couple of areas that I'd like to draw your attention to of the discussion today. So in March, we saw an increase in the number of moderate validated incidents, and that's the alert for the paper. They are multifactorial and are detailed further within the report, but what we are seeing is an increase in birth injuries within the service. So over the last 2 months since writing the report in the month of April, we've had a further 2 birth injuries that relate to skulls following instrumental, so forceps births. And whilst it is a recognised complication of a forceps birth, what we seem to be having is a trend that concerns us as a division. So we have gone through an internal process of reviewing the fractures, and the majority of the fractures were identified once the babies were discharged home. So obviously that also has implications for safeguarding and a concern around non-accidental injuries. So processes have been followed in collaboration with neonates, paediatrics, safeguarding services and perinatal. And we have reviewed all of the cases, and there doesn't seem to be any particular trends around practitioners, grade of practitioners, application of forceps. That you know, there's no concerns within those initial reviews. But in light of the concerns that we have, we are considering, and you know, it's for discussion today whether or not we should look for an external review of those, to go out to somebody and say, you know, we have looked at it, this is our findings. Is there anything that you can draw out in terms of learning or practice, competence issues? Because what we want to make sure is that we have reviewed everything around. Those reviews are extremely thorough. And if there is any learning to be identified, that we are obviously identifying that early. So that's what I wanted to really bring to the board, that it is flagging as a concern. We don't feel that there is anything, but just for absolute robustness, we would like to go out externally to the organisation.
Thank you. I'm going to bring Aziz in, but we had your hand up.
Thanks, Chair. Just to on that point about birth injuries, I have two questions actually. One is the point about the birth injury, which was the fractured clavicle of a baby discovered in community setting in a physical examination. The report says the delivery obstetrician performed a shoulder dystocia and did not communicate it, so the baby was not x-rayed and the fractured clavicle was not discovered. The action taken according to this report is the labour ward lead consultant will discuss this incident with the obstetrician. You know, I've had a fractured clavicle and it really hurts actually. And it doesn't say how long this baby had a fractured clavicle before it was discovered in this physical examination. This report is saying that a clinician has failed to communicate something which has resulted in harm to a child. You know, an x-ray should have been taken, it wasn't. That child will have been in pain, possibly severe pain, and it doesn't say for how long. And you've just said you've examined all of these and everything is fine. I don't understand that. I would have thought, you know, this report says this clinician did not do what they should have done, which is make sure this child had an x-ray, which has resulted in harm to the child. So that's one question. That doesn't feel right to me, but you know, obviously I don't understand all of the investigation you've done. The other one is the obstetrician who did not acknowledge or respond to a patient request to stop a vaginal examination, and the husband had to remove the obstetrician's hand. Now, if that happened to anyone I knew, I'd say it was an assault. If you ask someone to stop doing something, they should stop. And the obstetrician is closer to the patient than the husband is. And the husband heard that his partner wanted the vaginal examination to stop. And if an obstetrician is not stopping when a patient asks them to stop a vaginal examination, you know, do we want that person working for a hospital? I was just really disturbed reading that, and I just wondered if you could, if there's something I don't understand about this, or some further explanation that you could give me about that.
Yeah, absolutely, Aziz. And both of these incidents involve obstetricians, both of which are locum obstetricians. So the vaginal examination has been reviewed and reviewed by the clinical director and the lead obstetrician for labour ward. And I believe that information has been fed back to, in due process, to the agency for that locum. And I have again spoken to Annabelle, the CD, to pick that up there has been a piece of work that's been done throughout maternity services around consent, because this isn't the first concern that's been raised about consent. And that work is ongoing, and we have also sought support from Hill Dickinson in terms of doing some consent training for all parties involved, because it's important that the midwives also advocate for the women in those situations. So that's kind of where we are with the vaginal examination case, and obviously it will be up to Annabelle and the team to follow that through and make sure that that training and that support is offered. In terms of the shoulder dystocia and the fractured clavicle, unfortunately, it is a fractured clavicle can occur during the shoulder dystocia. It is a manoeuvre that's used to support the delivery of the baby in this obstetric emergency. The failure on the part of the obstetrician was around not documenting the fact that there had been a shoulder dystocia that had occurred, and therefore the x-ray of the baby didn't take place. However, the midwife who examined the baby at 48 hours of age did identify that there was a fracture, and the baby was obviously transferred back into the unit and had the appropriate care, not taking away the fact that there was an issue with the documentation, there was an issue with the communication, and that wasn't escalated at the time. But again, that is very much up for the obstetric review to make sure that that actions from that are taken forward around documentation and discussion with that individual doctor. As I say, it's not a theme that we've seen, but it is an incident that we need to take seriously and make sure that we've got robust processes in place.
Thank you. Thank you for those questions that have been very important. I think hear your response to itself. Raising a few concerns from yeah, just to some of those come to my colleagues who repeat and then Jeff.
Thank you, Jen, and thank you.
Sorry.
My apologies.
So it was Jude and
My apologies.
no, Jude.
Thanks, Faith. I think your question to us, should we get someone to look at it? And I think if the team think we should, then we should. We shouldn't. My personal view should stand in the way of that. And particularly, I think because we've got a good relationship with Region and the work we've been through this for the position with Region colleagues who've been working with us on our improvement journey. Can I just ask, in your review, long time since I've done midwifery, but paediatricians often examine some babies before they leave hospital. I don't know if that's a thing for all births or whether their sections are different things, but did you look at, I don't know if that's a thing anymore, but is the paediatricians involved in examining children or not, and did you look at that element? And then my final question is, there's another fall in here, and I know at Q&P we had a series of falls, hadn't we? And we put some control mechanisms in place. I know much of them were from bed, mother asleep. And I don't know if the work that we did on falls, baby falls, extended to the labour ward or not, and if there's more we need to do, just roll that out a bit further.
Yeah, so in terms of the examinations and the involvement of paediatricians, they wouldn't normally examine a baby now unless there was an escalation. So at a instrumental birth, the neonatologist would be called to attend the birth. But as long as the baby was born crying, didn't need any further resuscitation, there wouldn't be any further examination. The midwives would then perform the daily examination. Anything of concern, they would escalate, which is what happened in these cases. And then they would become involved at that point. In terms of the baby falls, as you know, we have done quite a lot of work around baby falls, and absolutely a lot of the work was done around the postnatal period. This baby fall actually occurred on labour ward, as you say, Jude. And what happened was, in this case, there was a failure of everyone who was in that room at the time to recognise that this lady was in labour. So she got up to go to the toilet with the baby still in utero, and the baby was born very quickly. And therefore, that's why the baby
it wasn't a drop as such. It was a labour recognition issue that was highlighted in that particular case. And the reason that I'm bringing these cases to you is that they have all been reviewed. They have all been classed as moderate, and it's important that, you know, we are now just starting to see a bit of a trend and an increase in this last month of moderate incidents. So it's to kind of alert you to that and to say this is what we're doing about it, and to make sure that we're not seeing any significant trends that then continue.
Thank you very much.
Thank you, Chair. Now it's my turn, probably. Thank you, Faith. As always, a comprehensive description and detailed report, and we've done some really great work in terms of just how we move forward progressively with this. A couple of points for me. Again, like Jude, I'd be supportive of an external review. I think we've generally, not because we think that we find anything particular, but given the history of some of the challenges that we've had and the approach that we've taken in terms of just being completely transparent, I think cooperating with other colleagues from other centres in terms of just maybe a fresh eye would be helpful. So I'd be very supportive of that. I want to pick up just a couple of things related to some of the practice described here. So first of all, I think there is a nuance in terms of oversight when a doctor comes through an agency. So they will have a separate responsible officer that isn't us. And so I will pick up with the team just because I want to make sure that we have done everything that we need to in terms of escalation, including, and I haven't been involved in this particular case, but I would expect that to have been escalated through Medical Director at Oldham onto our responsible officer to ensure that there is that connectivity and to ensure that the relevant responsible officer has taken whatever action they need to from a regulatory perspective. So I'll pick that up with you and kind of our team just to make sure. Consent has been raised a few times. I think our expectation is that all of our clinical colleagues, my focus will always be a little bit more on our medical colleagues, but certainly all of our clinical colleagues should be very comfortable with what is required from a consent perspective. So if we think we need a little bit more work there, absolutely we need to be doing that, and we can have a bit of conversation about how we achieve that bit. The shoulder dystocia one, again, I think is interesting in terms of how we're framing the response. And again, I'll pick up the detail because sometimes some of that might not have come through. I think there is a difference between informing someone and making them aware that something has been picked up in their practice. But then what we need to do is ensure that if we've identified any additional training that is required for them, if there's any dissemination of the learning, because as clinical practitioners, all of us will sometimes have an oversight or an error, which is, and there's a risk that other colleagues may do the same. So it's one thing to have maybe tackled it with one colleague. I think a bit of assurance around what we've then done to ensure that we minimize the risk that it will happen again elsewhere. It's just something we probably need to pick up. And I would expect that if there is something that has been identified that's led to an investigation, that our medical colleagues would include that in their appraisal and maybe just do a bit of reflective piece so that they can have a constructive discussion with their appraiser around. Thank you.
Thanks, Chair. We've been asked whether we believe there should be an external review. In light of what we've heard this morning and what's in the report, I think that the answer has to be yes. Also, the case that Aziz raised about the vaginal examination, the report says that the family was seeking a referral to GMC. There's no information here to say whether that referral happened. I think Faith said that we, the NTA, informed the agency who employed this local nutrition. I'd like to know at some point what they did with that information. I think we have a duty to follow this through.
Thank you. I just want to just point out with Rachel in this one.
Yes, so I believe that the clinical director has met with the family
to discuss the incident and then want to refer through to the GMC, and absolutely is supportive of that process. I am aware that it has been escalated to the agency, as I said, and I haven't had feedback from Annabelle yet, but obviously we'll pick that up through the process and the conversation.
Rachel?
Thank you, Chair. I had a question, Faith, about it's on page 10, the D393480 title assault. In there, it has the phrase, this was as a result of cultural reasons. I think for me, that wording feels quite clumsy and vague. And I think for the person who was assaulted, that's a member of our staff, I wonder if that could be explained in a slightly different way, because from this report, I can't see how we could learn from what happened, because we've not really said what type of reason this assault was attributed to. I'd really appreciate if you could have a look at that and think about how we could tweak that a little bit, please. And also, I'm interested in the unplanned hysterectomy as well. What it doesn't say there is whether or not consent was obtained by the patient and whether or not alternative measures had been considered before that took place. If you could just talk a little bit about that for me, please.
Yeah, so in terms of the unplanned hysterectomy, all ladies that are consented for a cesarean section are advised that one of the risks of that operation is the risk of an unplanned hysterectomy. So this lady would have been consented for her cesarean section, which would have included risk discussion around hysterectomy. Now, the decision to make a hysterectomy is a very challenging one for clinicians and is always done as a last resort. So you'll note that there is a mention of a device called a Bakary balloon. So this is a device that's used as a tamponade against the uterus to try and reduce the bleeding or cease bleeding during a postpartum hemorrhage, which is one of the tools that is used to try and prevent hysterectomy. On review of this incident with both gynecologists and obstetricians, it was felt that the hysterectomy was the only option in this case. And this lady would have been awake at the time of the cesarean section and then would have converted to a general anaesthetic for the hysterectomy. So that discussion around hysterectomy and next steps would have been taken with the lady, albeit in a difficult situation where the lady is, there's a lot going on, but she would have been consented as well prior to going into the.
Thank you, because as someone who signed that form twice, I probably on both occasions had absolutely zero expectation that would happen. So the point you've just made, though, she came out of theatre and then went back in, and it was at that point that there was a further discussion from what you've just said, where it would have been really reiterated that this is a possibility. Have I heard you correctly there, Faith?
Yeah, just she wouldn't have gone back into theatre and come back, but they would have kept him in theatre and converted from a local analgesia through to a general anaesthesia, and that discussion would have taken place at that point.
Okay, thank you. Yeah, because what I was worried about is I'd gone in to happily have my baby and then been told, here's your baby, and unfortunately we've had to do this as well. That would have been incredibly shocking. So thank you for that. And your thoughts on the assault one, please, Faith?
Yeah, so absolutely, Rachel, happy to kind of clarify that a little bit more. This particular case was a gentleman, a husband, a partner, didn't want a male doctor to examine his wife. So that was why it was phrased as cultural reasons. Right? This wasn't an incident that was attributable to particularly, any area, but their cultural beliefs around who they wanted to examine, who he wanted to examine his wife.
Yeah.
And unfortunately that escalated, and the doctor was asked to leave, and we did support the doctor during that point. We did then find another clinician to support care in that room so that he didn't find himself in that situation again.
That's great, thank you. I mean, obviously, any of our staff being assaulted is entirely unacceptable. I wonder though if attributing it to cultural, because actually somebody could just have that preference as well and have a strong view. I think using the phrase cultural reasons, I personally don't find it particularly helpful. I think it might make barriers for our staff to assume based on culture as well. But thank you for that explanation. Thanks.
Thank you, Faith. So we've heard a number of comments and some points of clarification on the cultural aspect. I agree with Rachel there. It is about someone expressing full choice, because we use culture in that context. It can reinforce assumptions that you can I only know how that goes. You experience and have to understand that. Thank you for being the candid and open in the conversation. We've identified, well, we've all discussed and identified, I'm sure, matters which resonate with us very strongly. Clearly, there is a role for an external review, absolutely, in all these matters, regarding the issue around locum doctors and the locum qualifications. I think there needs to be some wraparound around how we know that they come with no victory, how we know that they are accredited, if one can form their scope of practice. Then I don't know how that works, but I would like to understand all of those elements, because there may be trends against a particular locum or someone else we bring in locum that do those protective items. It's our duty of care to address those factors. And just to the point around non-accidental injury, I think again, we need to be very careful and sensitive about the external review. Will, I'm sure, be very comprehensive in how it looks at the data, how it looks at the full set of circumstances that led to a particular outcome, and will address how we feel about that and not being on site, and have more conversations with other colleagues. Because I can see how things may quickly escalate, looking out to the individual to blame and then to the hospital. That balance has to be met appropriately and be shown to be transparent. The final in terms of reference will be to reflect that transparent. So thank you very much for that. I'm going to be Owen for that comment.
I think that Tim Crowell's on to do as well. There's just a little bit of unease I've had just listening to this conversation, and what the unease is that what I don't know is if the service users in this case or the colleagues who are involved have been made aware that any aspect of their care may have been discussed publicly. And I know that there's attempts being made to anonymise, but the nature of the conversation, the questions, just leave me with a little bit of anxiety about the nature of this discussion. And I think there's probably just a learning point for us, Chair. I regret I've missed this, but I think there's just a little bit of a learning point for us to check. And if any service users or patients are watching at this moment in time, just to give my apologies. But I think that this is something we just need to be really, really clear on, given the nature of the discussion that's been had, because there is a possibility that the nature of discussion may lead somebody to think what they are talking about me. And I just think we just need to just take a reflection on that and maybe just think about. I think that it's absolutely the case that there's several elements of this report that you would want to be out in public, but it may be that there are some points where you might not want to do that unless you've got an approval from particular service users involved. So I just felt I needed to make that point given the nature of the discussion.
Yeah, no, I understand that. So whose responsibility was it to learn the paper? Yes.
So I'll take responsibility for that, and I'll work with Faith to make sure we get the right level of information here. That is my responsibility.
I think it's all our responsibility there. I don't think it's an individual matter.
I think that I understand what you're saying there, but we don't have the expertise to feel that it's coming to our domain for us to consider and respond to. So I think those are levels we need to. But I do take the point that we're in the discussion. It was our responsibility. Do take. I think there was one final.
Just to make it clear,
question.
when we learn from this, we balance the absolute importance of ensuring that individuals be set if there's any risk of their individually being discussed. Absolutely get that. But we need to balance that with the importance of being open and transparent in the public domain. So rather than reaching for the Part B button too quickly, can we focus as much as we can on anonymising issues so they can be discussed in the public domain without identifying people? And obviously, that is absolutely impossible, fair enough, but there's always a risk we end up talking about difficult issues in Part B for all the right reasons, but not somehow, sometimes how it's seen externally, it looks as if we are not prepared to be as transparent as we should be. It's that balance, I think.
Again, just for clarity, I'm not running over suggesting that the road we should be going down is certain conversations being given in Part B. But if I'm an individual, I'm a family member, and important as a result of this conversation, I feel that the conversation being had about me without my knowledge, I personally don't think that's acceptable. So I think there is a thing about we just need to be clear about that and get that written down. It's not really for me about a question of Part 2, Part 1. It's really a question of, you're saying nothing about me without me. I think that's an important principle that you need to take home. Thank you, Chair.
Yeah, you don't come back.
I think it's the balance between alerting us to something with the relevant level of detail for the board to know, are there any trends, is there anything to be aware of, versus that something's been concluded. So I think what Faith attempted to do is bring something as early as possible with as much information as possible. We've just strayed a little bit too far into some areas where things haven't been concluded, which I think is an important point. But I do think there is a place in a Part B to talk about things which are emerging, which are identifiable because they're quite unique. So I think trends are helpful, but when you're talking about some individual cases, so I don't think that's about not being transparent after an investigation is concluded, but whilst an investigation is underway, you can end up drawing the wrong inference from what might have happened. So, and I do think when we conclude investigations and complaint investigations, we would talk about whether or not we could share the learning. So I think this is a bit of a process that we've already got in there. We're just probably straight out with it. So we'll work to make sure we've got the right level of insight and transparency, but also that we're alerting the board in the appropriate part of the board conversation about things which are to be identifiable.
Thank you. Tim?
Yeah, I mean, it's just to flag a kind of related point. I mean, one of the things I attended last couple of weeks ago was the Year 7 launch of the maternity incentive scheme training by NHS England. And that's an important piece that comes to this board with regard to 10 safety actions, our self-declaration. One of the kind of developing areas of that is in relation to clinical workforce planning and kind of the auditing of locum short-term certificate of eligibility, and also the Royal College for longer term locums as well. So I think kind of some of that evidence, I know we kind of strayed into detail, but get us back to where we might find assurance through a process which we self-declare, that I think would be one route to do that.
So, suggestion. Thank you, Tim. Are there any final points?
Thank you, Chair. So we'll be very supportive of Tim's last comment, and as we move forward both with what we're doing from a clinical leadership model perspective and specifically work that should have happened within gynae because it impacts maternity quite clearly because most of our obstetricians are actually also gynecologists. We will further develop the workforce planning in that space. I just wanted to make a really quick comment around the transparency. It's very, very supportive of that. And as discussed when we were talking about the external review for the fracture skulls, etc. But my view that I want to share with the board is that this level of detail should happen at the board committee level. So that's kind of a conversation I think would be very appropriate to get into in full detail within the QPC environment, for example, and that allows us to have open conversations about it without undermining any potential fertility issues. So it can absolutely be scrutinized, Jeff, and I think we just need to balance that with what is said.
Just to bear in mind, though, I think QPC, unless it is stated to be a part B, is a public meeting. So again, just need to get the balance right. Thank you.
Okay, it covers very comprehensive and important discussion. So I'm going to take you forward with this, but to move forward, we need to address the challenges and issues that we have. So Faye, thank you very much for attending. We remember report and I suggest we take a 10-minute break here at this point. So we come back at 10:12. That's okay. And we'll come back to the People Education Committee. Speak down.
Just keep it simple. Thank you.
Or your charger.
So, colleagues, welcome back, and to those joining us on live stream, welcome back to we move to agenda item 13, and it's People and Education Committee. Aziz is going to report against that. Thank you, Aziz.
Hi, everybody. So the People and Education Committee met on the 23rd of April, and you all have the report. But let's just, I just want to go over a couple of the alerts, actually. In-month sickness, you may have noticed from the integrated performance report, in-month sickness is reduced for the last 2 months. But actually, it's still higher than where it was a year ago. So the rolling sickness average is still increasing. And but there is a big focus on this. There's been, top tips published for managers in having absence conversations with colleagues, a review of the correlation between high levels of welcome back conversations and lower levels of sickness absence, to share some best practice across the NCA, and a new video, a learning video being produced on how to do welcome back conversations, because we realise some managers aren't completely comfortable with this and with the new sickness policy. Appraisals have remained below target for over 12 months now. The current performance metric shown a marginal decrease. Bury, Rochdale, estates and facilities have achieved over 90%, which is what the target is. I would encourage all exec and non-execs to, if they haven't already, to agree at their appraisal dates, because we're having ours now, and also to encourage your direct reports to complete appraisals, because as we know, those conversations with members of staff are really important for their development, training and well-being. We discussed progress on Oldham's CQC plan, in particular actions to ensure that colleagues at B7 and or above must attend the NCA ALDP programme, and that they have a clear objective to undertake ALDP2. This action is now overdue, and the committee are not assured with the response received by the leadership team at Oldham. It was agreed at the meeting that the Chief People and Strategy Officer would discuss this with the Chief Exec and Oldham's Chief Officer. In terms the other bits, I just wanted to mention that all care organisations and corporate services have achieved over 90% compliance target for core and mandatory training for the first time this financial year. So that's great, significant achievement. And that in terms of cross-committee working, that the freedom to speak up responsibility from Chief Nursing Officer will move from Quality and Performance Committee to the People Committee, and I am the freedom to speak up champion too, so we've decided that makes sense. And that's all from the People Committee.
Thank you very much, Aziz. Are there any comments or questions for Aziz? Like you, I'm delighted to hear we achieved 90% compliance with mandatory training. Truly important, isn't it? We're on the right side of that for a whole range of different issues. I would still like to understand whether 10% is causing a concern, particularly if that's in maternity, or whether there are any other spots which may be emerging in non-compliance. Just want to keep pushing audit as needed. If there are no comments or questions for Aziz, can I thank you for your reports, and can we move on to the escalation matters? Kirsty, you're going to speak to that.
Thank you, Chair, and I am presenting the assurance to the board and to the public that we have undertaken the fit and proper persons requirements which are set out within Regulation 5 of the Health and Social Care Act, and in line with the response to the CARC review. The report sets out the rationale and the overview in terms of the checks undertaken into members of the board. And the appendix included shows the return undertaken and submitted to NHS England. I think the report speaks for itself, Chair, so I'm very happy to leave it at that and take questions.
Yeah, thank you very much, Katie. It does speak for itself. Are there any questions? That report is accepted. Thank you, Katie. We move then to agenda item 14, research and innovation, and that's going to be presented by Carl.
Thank you. So the meeting took place on the 14th of April, and you can see from the paper the items that were listed for discussion in the meeting. There were no alerts from the meeting other than to note that the NCA decision has been taken to not progress with the GM community dermatology tender submission, which I think we'd highlighted previously at the previous meeting, which was only in March. In terms of the advisory section, a number of items were discussed. We received an update on the risks to future growth and expansion of the clinical research facility because of the challenges they have with current accommodation. There was a session on the 30th of April, which I wasn't able to attend, which was a board meeting, and Bill Calra and Steve Wogan came along and presented the research strategy and the work that's ongoing and the future opportunities. And I've spoken to a couple of people since then, not everybody yet, and had some really positive feedback on how informative and helpful that session was and how it's really highlighted the activity that's ongoing and the great work that we're doing. And I would like to go back to them and give them some feedback from the board. So if there is anything in particular when I finish providing my update, I would like you to either drop me a note directly or just please share in this meeting, because they've made the time and presented. And I do know they took the opportunity to talk about the challenge on accommodation. So I won't say any more there, other than they were directed to progress a business case with their finance director to be able to move that forward. We also received an update on the future funding for the Centre for Clinical and Care Research and what funding has been committed for the next 3 years from December 25, which is 95,000 a year. And at the time, the centre was waiting for the outcome of the bid to North Care for £118,000 to continue internships. The clinical strategy group provided an update on their key work streams. I won't go through them all because they're in the report. And we are expecting our clinical strategy to be developed by the end of Q2. So there'll be more to come on that. And we've already talked today in the meeting about the fact that the digital risks have transferred, BAF risks have transferred over to the committee, and we will be reviewing those. And then the final item I wanted to highlight was that in discussing the clinical strategy, it was suggested at the board meeting that we have a further board development session on that once it's available, to give us the opportunity to look at it in more detail, and perhaps we could do that later in the 25-26 year. Thank you.
Thank you very much, Carmen. I'm going to ask my colleagues if there are any questions or comments, and if not, can you share some feedback and highlights from the meeting we had with the research team last Thursday? Wednesday. Last Wednesday.
Last week.
Just a quick comment, Carmen. Since the discussion at Research and Innovation Committee, I picked up a conversation with Steve Warby in relation to the accommodation challenges he's articulated. So we've agreed some next steps in relation to that.
Great, thank you.
And just in terms of overall feedback from the session, sure colleagues will like to. We all welcomed the opportunity to speak to them directly about what we're doing. So much activities, global and local and regional in terms of impact. The stretch and the breadth of the specialist areas that they were looking into were insightful, and I think for many of us in the room who are non-research or non-academic, students and when maybe don't have that thing, absolutely acknowledged and appreciated the amount of impact in terms of development, innovation, research activity, and landing to improve the way we deliver our care, not just to our NCA community, the families and colleagues and patient services, etc., to the wider footprints that we extend into across GM, regionally and nationally and internationally. And just the breadth of experience that we've demonstrated in all levels, from juniors to very established consultants and specialists in their field, was just incredible. And I think we did listen very carefully to the matters that you raised around the challenges. You mentioned some of them in your reports. We've acknowledged them and we begin to address them in committee. That is our start of 10.
Thank you.
Thank you very much. Thank you.
Thank you.
Okay, so we do have a break here for lunch, but because you've had a break, I've been very generous with you. Can we continue for a while longer? Hopefully, the agenda, that's all right. I hope that's okay for me, or members of the public as well. So we will continue then with audits and risk, agenda item 15. That's with Tim Crowley.
Yep. You can see there are three alerts which just relate to our kind of ongoing scrutiny of overdue internal audit actions. We also looked at the interim review of the data security protection toolkit, and we received the statutory requirements review. So they're in the alert section. The advice section, it kind of covers off all the year-end kind of processes. So those included at this meeting: draft annual report and accounts, draft quality account, and draft annual governance statement. We also looked at the provider license compliance, and service condition 7 is attached to this because we do need to approve that here. We also received the head of internal audit opinion and what's already been referred to the risk appetite support as well. Risk appetite paper. And with regard to that paper, the committee were very supportive of that direction of travel. But if I just bring us back on the cover sheet, there are 3 areas for the board to approve. So if we look at 2, 3 and 4, which is to delegate authority to the Audit and Risk Committee to approve the annual report and accounts on behalf of the board, subject to what's the final draft coming back and being circulated. Approve the amendment of the terms of reference, and that was in respect of redundancies and settlement agreements not to come to the Audit and Risk Committee, but as is conventional to the via nominations, remuneration and terms of office committee. And the final one is consider the NCA's declaration as required by the NHS provider licence in respect of continuity of service condition 7. So that's the availability of resources, and confirm the statement applies. As I said, that's an appendix to our AAA report. So it's specific agreement to those.
Yes, yes. So we see, Colin, you'll support the recommendations that Image has made.
Yeah, thank you. Just in relation to the last one, which is the licence conditions, we discussed it in the Risk and Audit Committee, and as we were present at that moment, that absolutely stood. But just to flag that we've got till the 31st of May to make that final declaration, and if there's anything that changes subsequent to that, we will make board aware outside of this forum.
Great. So on that basis, can we confirm more recommendations and confirm this recommendation? Can you speak?
Yeah.
Important. Thank you. All right, thank you very much. Just at one point on the Tim, I know that you've been aligned on this in terms of overdue audits. Are you now confident that they're being tracked effectively within the assurance context?
Yeah, yes. I mean, as you can see, there are still things we're kind of focused on, and particularly the limited. There are still some overdue ones in respect of some important areas, but the process is there, and the subcommittees of the board are allocated those and are tracking those. So, and I think you board may recollect, probably a year, 18 months ago, there was a large number of these. Those are now down to a very small number. That's kind of thanks to executive colleagues who have kept the focus upon this.
Oh, thank you, Tim. Okay, colleagues, we then moved to agenda item 16, change portfolio, welcome you. And there's only you in the end. So, Owen.
Thank you, Chair. This is a report that's kind of struggling, I think, two approaches, which I'll come to talk to. So what I'll describe in terms of what was being considered in April in terms of the alerts. So we've got the clinical leadership model, again, after some progress, kind of reduced back to a red due to capacity issues and delays in the critical design reviews. We've got outpatient excellence, takers excellence, again, reduced to red due to financial benefits being significantly below targets. But again, I caveat that with what I will say a little bit later. Urgent and emergency care excellence, governance and delivery status still remain red due to disconnection between the programme plan and scope. Nursing and midwifery and AP's governance delivery reduced the rate due to financial benefits being below targets and lack of updated programmes plans. Medical workforce governance and delivery still remains red due to a lack of attendance and connection with care orgs, so still some work to do there. And medicine management, which is probably not being decided too much historically, reduced to red due to incomplete impact assessments. So again, hopefully that's an aspect that we'd like to see addressed. In terms of matters to advise, and this is where I do look at the cost point, in terms of the programme focus, clinical service excellence, there's been a great emphasis agreed at the Change Portfolio Board and also subsequently in the Finance Committee that future monitoring and assurance will focus on productivity gains rather than cash releasing benefits. Some of that is down to the lived experience over the last 12 to 14 months around that and a decision to kind of make sure it's the minimum that we do focus on the productivity side. That doesn't mean to say that we will automatically therefore not be seeking cash releasing benefits. But again, the lived experience has been certainly over the last 12 to 14 months that cash releasing is not necessarily what the primary focus of this piece of work should be. It should be productivity gains. Again, there will be some form of oversight for the Change Portfolio Board, but that will now move from kind of the regularised kind of monthly to a kind of a more quarterly focus with what is the performance and planning group, which Jude chairs, and also the Finance Committee kind of being the regular point where the productivity conversation certainly will take place moving forward. Again, just in terms of matters to advise, there was approval of capacity until October around the clinical event model, which a lot of discussion around that, but we landed with that recommendation. Well, I think quite important because I think the maternity improvement programme is probably the first programme that has kind of been along the stages of Gateway and has currently got now approvals on Gateway 3. There is a Gateway 4, which is 7 months down the line, which we will revisit. But I think it's just worth noting that that's probably the first until since we've had these arrangements that we've seen a programme move particularly to that stage. And again, the service review, PwC service review, we've determined that there are no quarterly updates now required to come back to Change Portfolio Board, but there's still elements ongoing related to the service review, some work that will be doing now with the MIA related to certain aspects of the service review. So, but it's not on the radar. There's still some important elements of the service review that need to be talked about. We've already discussed the financial sustainability plan. I think it made reference earlier that there's agreement that the Change Portfolio Board and Finance Committee should be received in the best place, so that's welcomed around that. And we also discussed Change Portfolio communications. And so the approval were in line with what I talked about, and that in effect the Clinical Service Excellence Programme oversight moved to the Performance and Planning Group and Finance Committee. The clinical leadership that there's increased programme capacity to October, and then it will be reviewed. And we've closed the maternity programme as far as we would describe it, and then the service review further quarterly updates. We talk about that, and I'd also just echo a point that I think Z's made earlier, and I think Cameron's also made. We did have a meaningful discussion about the risk associated with this, and some changes that we'll make as a result of the Change Portfolio Board. So again, I think the comments that Aziz made about this kind of being iterative and live is reflected in the Change Portfolio. My opinion. Second question.
Thank you. Are there any questions for Owen? Aziz? Aziz, please.
Thank you, Rabina. Thank you, Chair. It's really interesting to see all the progress on all the different programs that we're doing, except one, and that's medical workforce. And it seems that month after month, this RAG-rated program says the same thing. It says lack of attendance, lack of connection to care orgs, program scope and plan not yet developed. But for the first time, I've seen it say less than 60% of CIP target identified, and given a really tough financial year, it seems that this is a program that we haven't got a grip and movement on, unless I'm mistaken. And I just wondered, you must see that, Owen, sitting in the Change Portfolio Board. What is there some sort of issue that we're not grappling here that is meaning that this one is not progressing like all the others?
Thanks for the question, and I will divert it to its audience lead. Rafiq, I do have a view, but I think Rafiq should have given you an answer to this.
Thank you, Owen, and thanks, Aziz. So I think it's fair to say that there have been some significant challenges in terms of progressing the medical workforce program over the beginning at the end of last year, beginning of this year. We've given it some added attention over the past couple of weeks, and we're coming to Change Portfolio Board with a description of the progress that's being made and our expectations in terms of how we can rectify some of the challenges that we've had so far. I think there's been too much focus on the lack of resource to progress things within the program, and not enough focus in terms of describing the detail of how we can achieve some of the targets that are articulated and bringing that into the Change Portfolio Board discussion. And as you've noted as well, there's been a little bit of an issue in terms of linking into care organisations, which we think we have an approach to resolve. So I think what I'm trying to say is, yes, it absolutely has been challenged as reflected, and we've struggled to progress it. There's been some activity over the past couple of weeks, which I hope will start to move the dial, and we're discussing in a bit more depth with Change Portfolio Board just over a week.
Any further questions, comments? Is there I'm going to receive his report, and then I'll move to Louise. Thank you.
Thanks, Chair. So I'll introduce the Portfolio Assurance Report under item 16.2. Just in terms of the format of the report, just one change I get to note, and that's following approval of programme closure of the Corporate Target Operating Model programme in March. That's been removed from the live programme scope slides, that's slide 6 of 40 in the slide deck, and transferred to the closed programme scope slide, which is slide 7. And it's been replaced by a corporate financial sustainability plan programme for the financial year 25-26. In terms of the assurance position at portfolio level, so as usual, slide 12 includes the graphs showing the trends, the overall government delivery assurance ratings, and 13 includes the summary dashboard. The total number of programmes in the portfolio in April remains at 16, 11 of which are being assured, and that's 2 less than the month before. Firstly, the Corporate Target Operating Model programme, as I mentioned, is closed, and so monthly assurance of that the monthly assurance of the corporate FSP programme, which has replaced it, hasn't yet started, although we have started some assurance activity around it, and in the next assurance report we'll see that commencing. And secondly, the maternity improvement programme was undergoing programme closure in April, and was therefore evaluated against the Gateway 3 programme closure criteria rather than the monthly assurance criteria. From a governance perspective, we saw a decrease in the number of green flag ratings from 6 down to 1, that being digital infrastructure remediation, and an increase in the number of red flag ratings from 2 up to 7. So that's the clinical leadership model, 3 clinical service excellence programmes, nursing and midwifery, medical workforce, and medicines management. And that was largely driven by the progress of financial benefits definition, which Owen referred to earlier. From a delivery perspective, we saw a decrease in the number of green RAG ratings from 5 down to 3, so that being medicines management, procurement, and digital infrastructure remediation. but also decreasing the number of red rag ratings from 5 down to 4, clinical leadership model, nursing and nursing, medical workforce, and urgent emergency care. And that's largely driven by the status of programme plans, those being off track. As usual, programmes with any red rag ratings are highlighted in the Matters to Alert section of the AAA report, and I'm forward there to allow the discussion.
Good to pause. Always good to pause. Thank you. Are there any comments or words of clarification, colleagues? Jeff?
No, sir. Just on the governance and delivery ratings, particularly on the governance side, it's a marked shift this month. I just wonder whether there's any further view from colleagues within the programme about capacity overall. I know the Change Portfolio Board has recently discussed capacity. Has that view changed in light of these data results?
May respond I guess the driver behind that, what feels like quite a shift around the governance ratings to red, is really driven by sub-criterion 3, so that's around benefits definition, and that's really reflective of the fact that this was month 1 of the new financial year, and the progress towards kind of CIP target having around 60% of the overall CIP target identified at that point in time. So it's consistent with what we'd see in the CIP reporting. So it's kind of reflective of that point in time. In terms of the general capacity, that was something that was discussed at Change Portfolio Board with regards to a particular programme around clinical leadership model.
Jim.
Yeah, thank you, Chair. I just want to raise an important issue to do with the clinical leadership model programme, and also there's a read across to the financial sustainability plan and the current challenge. And if I may, if I could just take us back to the Board of Directors meeting on the 1st of May 2024, when the board approved the design and implementation of phase 1 of the clinical leadership model. And for those, because there are several colleagues who weren't around at that time, what phase 1 meant was that we will restructure all support services to be trust-owned as opposed to care organisation-owned, noting there was no associated commitment to phase 2 arising from this restructure, i.e. it was a sensible thing to do, notwithstanding any future commitment to a clinical leadership model, and that it would involve a significant reduction, my words, my estimation, for clarity, no one else's, in the number of support roles, and thereby contribute to the cost improvement programme. Now, as we sit here today, we haven't done that. And I understand from colleagues that some aspects of that have been put in train. And just to give you a little vignette that came to me in the last weeks, I think colleagues may think that a lot of that is about the people function, a lot of it's about the finance function, but there are pockets of colleagues who are doing corporate roles out in the care organisations. I was speaking to your head of procurement, Joe Lever, about some potential cost savings through logistics and what people were ordering. And I said, what about materials management and logistics and how people order? And he explained to me that he had influence and management over the team at Salford. You have materials management teams at Bury, Rochdale and Oldham that aren't under his managerial control, and therefore he doubted very much that he could bring the influence to bear to realise potential savings. And that's just one small example where both I and other colleagues I spoke to in the day since have been quite surprised that that was how we're currently configured, which means that actually when the NCA was brought together, there were all sorts of pockets of things that would have been advantageous to do but weren't done. So bringing us back to today, we're looking ahead to an implementation of clinical leadership models by the 1st of April 26. It will be really helpful, which was the intent last year, to, for want of a better phrase, sort out and get that corporate restructure complete well ahead so that it doesn't get confounded and confused with the change to clinical leadership model. It will enable standardisation. Anyone, as I do, who speaks to care orgs and corporate functions every week realises how disparate other systems and processes across the NCA, and they will benefit from being brought together, wasting a lot of time at the moment trying to align things. It will really promote efficiency. We're in the middle of a very large cost improvement programme, and it will clear the path to CLM. So what I was going to suggest today was that the board might consider renewing its commitment to that corporate restructure. It doesn't need to denude in any way the services currently received by your care organisations. In fact, I think it would augment the support to them on a business partnering basis, and that we should consider that should get completed by the 30th of September this year, ahead of appointments of clinical leads, formation of shadow clinical groups, to help that programme, which we can see has some challenges in its delivery profile. It's had some capacity challenges. So that's, I think, something the board could commit to that would really help that programme. And I think every executive colleague around the table will find that they've probably got some action to take in respect of that overall trust to make that happen.
Thank you, Jude.
Thank you.
Jude. Yeah, thanks. I just, before the board sort of commits to what Joe's asked, there's nuance in that. So the PAR services, so admin and clerical teams, are not centralised yet. We are in a big programme of work that is taking on that centralisation, but we are doing that service by service, and it needs to be done carefully because we've got to go through waiting lists and understand the capacity in each team, and are releasing SIP as we do that. So that won't be complete by the deadline, but we do have a roadmap of doing that takes us through to the end of this year. So I just want to be clear that in whatever we document for the board, we understand that PAR is in a process. It has a good work plan. It has a good process of onboarding every service in a safe way, but it will have a different timescale.
As the saying goes, never assume, because it makes an ass of you and me. I think it would be fair to say that little vignette that was shared was a bit of a surprise to me as well. Been here 3 years and made an absolute assumption that procurement was under, every time that Jolie has come to a gossip group, absolutely in my head thinking, oh, that's one of the places that we won't have to go because we've already done that work. So that's what I would call a useful vignette. I think the couple of things I'd say is September's too long, given where we've got. It's in effect, it's a year since the board gave the mandate around getting this done. So I would expect that all of us are in a position, certainly executively, are in a position to enact that sooner. In September, I would say, subject to whatever personnel related issues that may be, any consultation that may be a part of that process, but maybe outside of this, get some clarity on that from Gertie about what and if may need to be considered on that. But September's too long. We need to get that sorted. What I would like to know is if there's anybody, Jude's given a nuanced version there of it, but I'd like to be clear in this conversation if anybody's got a dissenting view to that, what's just been articulated, that it is actually expressed now, so that we're really clear. So what is Chair?
So Suzanne, Beak, and then Jeff.
Yeah, thank you. So as George pointed out, I wasn't here on the May 2024 discussion and the commitment that the board made at that point. But for me, coming new into the organisation, irrespective of the CLM model and the work that's required to deliver that, from my perspective, the benefits of working as one across that function are huge. I've got a list of words that I was just thinking: efficiency, effectiveness, resilience for the team, focus, development opportunities, succession planning, and resources available to us. All of those things are really important, and the live conversations I'm having with my colleagues is around how we move fast at pace for that, for all of those reasons, because we want to unlock all of that. And it will gear us up for when CLM is live, and we will be embedded and supporting the organisation in a way that not only meets the requirements of the finance function of the organisation, but also supports Place 2. So we're having those conversations. So irrespective of that commitment, yeah, absolutely. From an estate and facilities perspective, we are as well. And I've had a conversation with Joe as well about procurement, which I wasn't aware of. And we had a conversation on the lines of we need to find a way through that. You know, there are benefits for all in terms of the, at least not the cost improvement benefits that we can access by doing that. So we need to find a way through those sorts of things. And it's with those vignettes, isn't it, that we understand a bit more, but absolutely need to grab all of those and push forward.
I'd add to your list, I think, Steve, not be one NCA specifically on that. Thank you. Joe.
Thanks, Jeff. By the way, the procurement vignette came out at the last finance committee, where we talked about a number of contracts that are up for renewal this year that are going to be dealt with by negotiated continuance with the existing provider, which is the majority of them, by far. And the main reason for that is apparently that it's a surprise to us that contracts coming up for renewal. Why is that? Because services know, but procurement don't. And I think procurement should be driving this, not services. Of course, services need to understand their own need and have the fans in what they get. Process, I think, should be centralised and gripped by procurement. And if procurement need more resources to do that, then they should get it, because I think that'll drive more cost efficiency. That probably needs some analysis, but where we are now, I don't think it works for me. So I agree with Joe's conclusions about what we draw from that vignette. Of course, I agree that we should renew the push on the previously called target operating model. Personally, for me, a target operating model concerns the whole organisation, not one part of it. So I'd work with a different name, but that's sort of irrelevant in the scheme of things. I would like to see much more depth to the analysis at the start of the programme this time round. There is a difference in my mind, all of these functions, whether it's HR, admin, procurement, finance, etc., from the strategic to the transactional. And I think we need to understand what we get out of this as one organisation by strategic capacity for these functions and how those core functions work together versus the transactional. And when we think about transactional at design stage, I would ask that we build in a greater challenge of to what extent those transactional functions are dealt with through greater digitalisation, so you have more self-service at the point of management, and or partnering with other trusts or organisations. These are transactional functions, and that's where the savings are. And again, that may not be 1 year, but that's where the volume will be. I didn't see last time enough differentiation between those things. Final point from me, the other side of the coin here, when you look at this from the external perspective, is yes, NHS is going to be much more one organisation, its corporate functions are singular, but the care organisations have a relationship with their localities, the locality boards, the place-based leads. That doesn't need lots of admin. It needs a really strong relationship at place level. And I'd still like to see more clarity of the design of the place part of the clinical leadership model, just as the other side of the coin of this issue. That final point, I do agree with Jude. Admin gets forgotten a lot of time on these issues. Admin, it comes down to it's admin that determines what gets done. Not the front line, obviously the right people in the right place for the right paperwork. So I do agree we need to do this with care, but again, I also agree with Owen, get on with this and make the same as fast as we
Then
Thank you, Chair. So I think all I wanted to highlight was, first of all, very supportive of the approach, but wanted to link this to the earlier discussion about some of the capacity challenges within the medical workforce programme team. And just as we recalibrate to ensure that we deliver on the world class, We just need to circle back to that because currently the team are working to slightly longer timelines, which is something for us to keep in mind.
Just a reflection for me, I guess it sounds like we're talking about a governance and process question here. And hearing what Georgia said, I look at my notes from May, we agreed to take those actions. In my head, then the CLM team would have taken that away and said, right, these are all the services, we're working through them, and actually use the change portfolio board to come back and ensure they're tracking the progress of those. If we're finding out services that have not been captured, then to me that tells me probably either the CLM program is not clear on which services they are covering, and that governance and process is not working. And the same with the change portfolio board, because to me the review there say, are we clear on the benefits? Are we on track for the plan? Should happen there. And I'm nervous that we make a decision about the procurement plan here. Or what other services there that we're not going to be able to pick up? So I think we need to go back and say, actually, what is the governance around the programs that we include here? And in my head, if we've agreed that the services all come together, then the change put down. The CLM group needs to go back and work out what those are, and then we use the change portfolio tools on those. I'm just conscious of making a decision on one service. I don't know whether this is the right place to do that and whether we will be able to cover all the things that need covering and not come back, a year later with the same question, because this is a discussion we had in May exactly.
Thank you, Chair. Yeah, just to respond to that point specifically. So, sometimes in change programs, there comes a decision point where actually it's over and above the competency of the program to decide. So the decision to actually sponsor and adopt this change became a board decision because it wasn't in the competency of the program. So to change the architecture of the NCA ahead of the NCA adopting the clinical leadership model formally, which to Jeff's point about place and that design work is still completing. So this was an action in anticipation of potentially CLM, but something that the organisation should do anyway in respect of efficiency and eliminating variation. And therefore it wasn't an action for the programme team, it was an action for executives. So all executives should then have gone away from the trust board and transferred people in their discipline, all those corporate disciplines, finance, people, governance, logistics, into their line management out of the care organisation line management. Meanwhile, the programme team, I think what they are, were focused on continuing the detailed design process, and there have been about 30 design reviews to date of the complexity of designing what the clinical groups would look like. So it was a deliberate actually attempt, if we go back and revisit that paper on 1st of May last year, to take away phase one from the programme, have it dealt with and considered executively by the organisation, get it done and leave the programme to focus on the clinical groups. That was the intent.
And I guess for me, that opens a gap that says nobody's giving oversight on the whole to make sure that it's happening. And if I think for myself, I'm thinking that's what the CLM group are doing. It's execution of a decision from the board. Yes, the executors are the executive, but the oversight in my head is coming from the CLM group. If that's not happening, then we need to think who is doing the oversight there, because they should be coming back to the change control board and saying, we have 17 services across all, whatever. These people have done their part, this one hasn't, and then we have the conversation with the relevant exec. If that's not happening, then it's maybe a gap of who is doing the oversight versus, each exec has to kind of almost govern themselves.
Well, I think
so maybe that's the gap in my head.
I suggest board oversight, board decision, and the board needs to have a framework that delivers the decisions that it makes. I don't think that can be delegated into a programme person.
I think that's correct, actually, which is why the linear you just described demonstrates so we can have lines that mean solution. But they're really very important to keep checks on how we put that in.
then in which case we probably then need an action at board to make sure that we're getting the oversight, because in my head, we've delegated it to CLM Group. They don't have that delegation, but we don't have the oversight here either.
We had the oversight to release with insurance and issues of that, but we need to strengthen that in the way that you described. But it is always good to see.
I think it would be good to get the detail, what are the services and where are they, and then we kind of keep that come back to say, yeah, there are 7, 4 have done it, 3 haven't, and then help them.
Thank you. Gertie and then Owen, please. Yes.
Yeah, thank you, Chair. I mean, I have to say, I think Joe's push and question to us all is really timely, and I think we have to remind ourselves of the lived experience of colleagues in the organisation who are going through a lot of change, and I think it's really important that we as a board are absolutely clear that this centralisation is important. You know, for all the words Suzanne has iterated, I could repeat them as well for the people HR functions. But we have colleagues who are in an interim phase before CLM, etc. And I'm not sure the clarity and understanding is there to Miriam's point around this is not an end point, it's a starting point. We don't create a structure or a team or a centralised function and stop. We continue to iterate, and we have to do that if we think about some of the things we've agreed as a board in terms of our increased rigour and oversight of recruitment and vacancies, etc. These teams will continue to evolve week by week, day by day. So I think there's something really important about us collectively standing shoulder to shoulder and saying, yes, we support this, yes, we will deliver it. And that it is important that it delivers alongside the interim arrangements, and it is about a precursor to land well the CLM.
Thank you.
So a few points to make. I think that there's something here which is centred in leadership. So if you take the procurement example a little bit further, Big Board has had oversight and been involved in workshop conversations about procurement and activity and shared activity between ourselves and MFT. So just want to think about that. And our colleague Joe has been quite central to that piece of work. And we've sent very clear signals that we are very positive about that. We want to see that happen. But then the same colleague, in the context of the NCA, has felt unable, or whatever the circumstances are, to be having that same thought process across the NCA. And you just think about that. That was quite aware around some of that and sort of ask the question. But then again, you've got some signs, because if you look at our last one workshop, when we had clinical colleagues here, we still had clinical colleagues who were in the same speciality talking about a broad aspect of it and talking about software. So there's a bit here where I don't want some people to suddenly have, amnesia or about the reality of what happened. Take portfolio board, suggest, through the CLN, has had more focus therefore on that aspect that is clinical. So if you take what's happening in gynecology and so on and so forth, there are several areas where now we are looking to sort of get rid of those sort of historical structures or architectures that existed, because we're saying, for example, gynecology and the good review of gynecology supports that service can give a better service to women through a more joined up reduction of unwarranted variation approach. So we probably had our lens more on what is happening in that clinical space, because that's where CLN takes us. What the procurement of it to be says, and we talk about leadership development in the clinically led space. What I think the procurement example gives me, and again I refer to the colleagues in the leadership position in procurement feeling that they can go and have conversations across the organisation in a GM space, but feeling inhibited for whatever reason to not be able to have those conversations. Now, please do not hear me say, well, that's about those colleagues alone. It's also about the environment and what messages they hear from other colleagues that may conflict with that ambition. So I think there's a restating that we need to do actually inside this that says when we're talking about opportunities to reduce unwarranted variation, it's not purely in the clinical space, it's across the piece. Why wouldn't you want to do that? Jeff does make a point, which I feel I need to say, that there are colleagues in our organisation that are in a space where they would see, and if they were hearing this conversation, there's a question for them about what does this mean for us and what does it mean by place. Okay, and I want to use place different. I want to talk about place in the context of a geographical location where we provide services that has been used to a degree of autonomy in how that service provision takes place. There are a group of colleagues in there who, when they hear the language of consolidation and so on and so forth, they ask a question about what does that mean for them. And I think there's some work for us to do in that space. And some of the things that we will subsequently discuss in this meeting later on today push us into a direction of consolidation. But therefore, we need to start being consistent. We need to recognise that there are those voices that are in geographical locations that have concerns and fear about what consolidation means. But I do think there is a central leadership point that is not just about having the right clinical leadership to adapt to the change that we're trying to make, but there's also a question which is about leadership in general, being able to adapt to the changes that we make. You know, certainly I took the cue from the May board meeting that we had, and that's why there were changes made to my executive report, because I heard the message around that. Now, some might argue, well, that was more straightforward for you to make. But I will just make a point. It is possible to make these changes. But again, I think that the procurement example is a really good example why some colleagues felt comfortable in one dimension of consolidation, which in my opinion is harder to do than the change process that sits within us, which in theory is easier or more straightforward to implement. And again, Maria, I just need to say, if you frame some of your input in the context of CLM, I think this is a board decision and straightforward in terms of it coming back to the board about progress. And what I would suggest to you, Chair, is that that you tried me outside of the change portfolio of the board, really coming back and advising on progress made. But I haven't heard, because I have to question if anybody had any disagreement. I haven't heard that, so I think that's a case of me taking that and providing you with an update at our next available board meeting about progress that's been made on that.
Yeah, I'm thinking about that. Actually, I'd like to ask you to, or put your way, is we have a mental board in June. We have an independent report there with a final report coming back to our July. I think. Thank you. Jeff, you have last word.
First of all, I think everyone is right. This is a leadership platform because, at its base, this is probably around Salford here, the remnants of Penn and Accused here. They've got two organisations. Here we are, trying to get rid of all that and have one organization. that does take leadership. In the end, that's a cultural, attitudinal issue. And therefore, the question, do we need singular leadership of a change programme for corporate functions? You know, if the head of procurement is struggling, that may be a struggle faced by all the corporate functions. Maybe singular leadership of them all, but to drive through the change programme despite the cultural barriers, but also to make sure you get consistency and effectiveness in the way corporate functions work together as a whole might well help. My other point is to come back to this issue of the relationship between place and this question of corporate functions. And I see no reason why you can't have both. In the same way we, as a whole organisation, aspire to both save lives as well as improve lives, we should, as a whole organisation, be both super efficient and effective as a care provider, and at the same time, be absolutely true different to our localities, to our local places, and having sat on the other side of that fence, to be frank, you don't much care who's running the finance, the procurement, the how people get paid. You want to talk to somebody who represents the hospital in your place and integrate that with other health services. So that it can and must coexist. I think just at the moment, two separate questions, and look for a bit of clarity on the place side as well as this side.
One thing I forgot to add, though, there's an adjustment required, Jeff. So executive colleagues will tell you it's a fact that over the last 18 months or so, we have moved to the model, for example, of having regular meetings now with our local authority counterpart leadership teams. That is a difference to what used to be the case. And so therefore, in this leadership model, the face of who people see into the future, I think is going to be different. And I've tested this out certainly in the authority community, as to do they see this as an enhanced, not denigrate to the past, but do they see this as an enhanced opportunity in that there is that direct dialogue with people around the table? The answer is yes. The question is, though, is that when we talk about place, it is not just about a local authority relationship. There are multiple relationships. But the local authority relationship is important because the local authority can be a place around some of that. So there's an adjustment for us to do in the way that we work that I think will go some way to how the new relationship evolves in place. But there's still going to be requirements such as, if you take a bet, it's going to require, I would call the fundamentals of site management to work through. And that's still some stuff I think we've got to work through in terms of this leadership model. But I wouldn't underestimate the change that we have to make and are making in our role as executives, because it's certainly the case, and I think you might have experienced this, that you would have been less likely to have regular convened meetings as the chief executive of local authority with the executive of the NCA, because that would have been described as the group, would have been seen as another layer. So all the feedback I've had so far is, while we still need to work forward on a work plan in each of the local authorities and 4 local authority places that we work in, there is real appetite for building that relationship, because in essence they feel that they're speaking to decision makers, which is a fundamental part of any change that you're trying to make. I still think there's still further work for us to do in that space though, because if I take dermatology, or if I take some of our neurology services, which are not geographically aligned to the 4 localities, as we would call them, what is the influencing and what is the relationship that takes place on a broader footprint? I think that is still further work in progress and needs some more thought, like that. But anyway, I thank you for just giving me the opportunity to learn daily.
No, that's fine. I'm just trying to clarify my understanding because I've either completely got this wrong or something else. I look at what we signed off last year in CRM. It had 4 things: clinical groups, functional enabling functions, and site and questions, and NCA leadership and governance. So to me, CLM covered all those areas, not just the clinical groups. Now I appreciate that everything can't move at the same space and they will come in at different spaces. So what you're saying, Owen, is for the NCA leadership and governance, that part we can take off because we've done it. We've done a lot of work on the clinical groups. But then maybe I don't understand what enabling functions are. I would expect that the procurement and all of that stuff sits there. Digital systems and all of that sits in there. So either we've misunderstood our ask here, or we need to go back and revisit something, because to me, those 4 aspects should be sitting as part of CLM and we are managing to them. It's not to say they should have all been finished. It's not to say that they are easy to do. They might move at different places, but that's kind of how I understood me working on the CLM, that it wasn't just clinical groups, but all the other 4 aspects. Just checking that I've not misunderstood that.
No, Miriam, I think the way you described it is correct. I can see how walking away from that board meeting 1st of May last year, I can see how there may not have been clarity about who does what next. But I think what we need to do now is acknowledge where we've got to, and to move forward with the restructure. The restructure was pitched under the banner of CLM, I guess, because CLM forced some thinking about how the organisation worked. And what we said was, actually, even if you don't do CLM, and that's what the paper said, do this. Because I think I said at the time, the NCA has been set up in probably the most expensive format that you could set it up. You created 4 mini trusts. And so because of last year's FSP, this year's FSP, ongoing FSP, it would be sensible to consider bringing all those corporate services together. Then I think there's a secondary question one normally asks is, if that's delivery, if bringing all the corporate services together is delivery, what capability do I need to do that? Do I need a change programme? Or do I just need to ask Suzanne and Gertie and Juliet and others to go away and make that happen? Because it's perfectly within their professional expertise to make that happen. And that still applies today. So I think the programme team stand ready, and I think there may be some subtle ways in which we can assist. But I think it's much better for the executive to take the lead and make it happen than go away and try and create another arm of a change programme, which we've read today already is resource depleted and is not achieving some of its key deadlines because it hasn't got sufficient capacity, which we're fixing. But it doesn't need, again, I've looked to my exec colleagues, if Suzanne were to tell me, Joe, I need a project team to make this happen, and she's shaking her head in the negative, then we could consider that. But I just don't think it needs that. All it needs is executive action. And to your point about, why hadn't we been talking about this? I'm sure because Gertie's given me some good feedback already. I've bored myself talking about the 1st of May 2024 and the decision for 12 months. So it's not as if people haven't been reminded, both within the CLM programme board and outside, here's an outstanding action that we need to focus on. So I think that there is learning. I'm sure you're right about how we initiated it and how we then tried to follow it through, and I include myself in that. But I think my prime interest today was saying, how are we taking it forward? What I'm hearing is executive colleagues are going to lead for their areas. I think the programme team can point into any areas that we can see that people might not be aware of, like the logistics one that we interestingly uncovered a couple of weeks ago. But then I'm sure the execs are quite capable of making this happen in short order, if that helps.
And I agree with you on the execs doing the execution. But I think what I'm expecting, at least in my head, is the CLM team program or the change portfolio board has oversight of those 4 things. The executors might be the execs that there's no program around it, but that we have oversight to say the NCA part's done, the enabling functions, we still have a gap. That big for me sat within either change portfolio to bring together. It's not necessarily to say you're executing it there or we're creating multiple project teams. That's not what I'm saying. So I think that versus it's kind of being oversighted at board, I find that a bit.
So Mary, if I may, and colleagues, if I may, I think it's been this to we haven't going to take all some of the very important points we've made. And certainly it's been a great example of how integral to our development and our own learning, we pause and we review and we reflect on what we've missed out on. But some of these have been victim of this conversation, so I feel going forward, we will have that line of sight. And the leadership point you mentioned around, focus on clinical, absolutely not the right reason. We needed to align that a bit in-track approach with more professional leadership. So because we didn't go that way, we're outside of procurement. We need to bring all these things back. And maybe something else that we'll find through this process that we haven't identified and need to strengthening. So I'm confident, based on what we have heard already, that you have enough information to grasp the key challenges we put forward to our balance of board. We're also we're going ahead with these very difficult decisions we have to make. If we are not clear, we cannot ensure our colleagues will be clear about our proper next step. And some of the legacy issues, I don't want to lose sight of that. We still have legacy issues where people do see themselves in their care organisations and not part of one NCA. And when we had the clinical presentation, ENT demonstrated that very strongly. They talked about, I can only locate this data and locate this work in my care organisation and not NCA. So therefore, we hear that I see it resonated with me. There's much more work to be done. But thinking, Rachel, I know that you had a question. If you'd like to ask them after the meeting, unless we need to comment further thoughts. No, okay, that's fine. Thank you very much indeed. Can we move on then to coming to accept first we received the change portfolio assurance report from the relief and the recommendation cited in relief 1 to 3. We are noting and acknowledging, please, colleagues. Yes, thank you. Next agenda item is governance, item 17.1 and 2. Then we're in your hands now.
Yeah, thanks, Chair. I just ask that colleagues take the paper read, know the contents and support the recommendations that are outlined.
That's so quickly. Okay. Acceptance or recommendations, no point of clarifications, no concerns. Thank you very much indeed. Agenda item 80 is communication strategy. Julie? With you.
I know I've got the final thoughts, so I'm hoping that I can get the energy up with this exciting paper. So I'm hoping that colleagues have had an opportunity to read it. I'm not going to go through the whole thing. I just want to make a few points. And just to be clear in terms of this, it is a draft. And the reason I've done that and taken that step rather than bring a fait accompli here today is so that we can seek both approval on the shift to two-way communications and also the 7 communications topics that we've identified for this year. And that's really important as a group that we find that. My intent then will be to bring back a sort of more polished, designed version for full sign-off in July. So I just also want to thank the colleagues and my communications team who worked really hard on this with me. It's not just my document. There's been a lot of work done on this one from them as well. The opportunity to do that. So it purposefully a 2-year strategy because we've got so much going on and we're facing a lot of exciting times, a lot of change, a lot of challenge. And I think it's really important that our communications reflects that and we stay current. And also there's quite a bit to do, but I want it to be measurable. So you'll see within the report that for every objective we have, there are some smart actions and we do intend to track those and report us back to the change portfolio board. So just in terms of a couple of things to point out that I think are really important, the communications objectives, there are 5 of these, 1 around our values and building those into everything that we do. Number 2, make our communications two-way, which is really the most difficult
crux of this strategy is kind of doing more to have conversations, not just kind of pushing information out one way, which we've traditionally done, and we're not alone in that. But public sector organisations, we tend to do that. Some of our communicating with our people, and we're getting that right for them, giving our patient services users confidence in our services and decision making, and then working with partners as well, which is a little bit of a new area for us as a team. So we've really given that some thought in terms of what we want to do. As said, each objective has got some smart actions that we want to get us where we want to be within the 2 year period. And you can see those in more detail in the report. The most important part of this are these topics, these communications topics, because we're a massive organisation and we've got a lot to say. And as we've seen in these last few weeks, we're trying to send out a lot of information to our colleagues on various different subjects. But the consistency of some of those messages is really important to being able to remember them and react to them and take action. So we know that people need to hear something between 6 and 8 times to really understand it, and to understand what to do with it. So on that basis, we've chosen these 7 kind of topics that we will create what we call a message house for. So basically just a set of messages that every time we talk about these topics, we'll repeat the same messages. Everybody gets to see them lots of times and understand them. So we've picked 7, covers a wide range of things. Values and behaviour really is important. Reducing patient waiting by treating more patients in primary care or community, which supports obviously the left shift agenda as well. So we've started to do some work around that already. Clinical leadership model, financial sustainability plan, digital strategy, treatments prevention, again, another one of the strategic objectives, and then anchor people, which I'm just going to talk to you a little bit about. So the strategy work that you know. So they're the topics. Just one other thing then on anchor people. So this is around, and it's a concept, and it's something that Owen's kind of spent some time thinking about and describing to Gertie and I. And it's quite simple really, in that you have we have anchor institutions that we all understand what they are and we're aware of those. But these are the people within it, and their role as anchor people. And I've given you an example there in the strategy of one of our doctors who, one of our consultants who, consult them in the day, and then in his spare time he does mountain rescue. And he talks about how he's able to transfer those skills both ways. So it's genuinely just that. How do we get our people to use the skills that they have at home to benefit us here at work and their colleagues, and vice versa? And I've got some lovely examples now of this going. I've come across someone who's a pilot, someone who's a published author. I've got people who come into work and do yoga with colleagues to relax at lunchtime and to help to reduce stress and stuff. So we're getting some lovely kind of examples going. So that'll be also a focus for us, is, how do we talk about people as people, not just people at work? So I'm going to pause there because I feel like I've just given you a good run through and then take any comments. And what I am asking for, just to go back to the ask the board chair, if I may, is for both to review the strategy and agree the shift towards two-way communication, to agree the 7 communications topics for this year, and then to agree that I can bring the final version back to July. Thank you.
Thank you, very well done. Are there any comments or questions? Is there you had your hand up?
Thanks, Rubina, and thanks, Judy. I mean, Judy shared this with me beforehand, but there wasn't time to take any of my comments on board in terms of the strategy here. But some sort of overriding thoughts on this was, on page 4, communication in context. I just thought the way the clinical leadership model described didn't sit right with me, and I think it needs to say something about putting clinical leadership at the heart of our treatment of patients and service users to remove unwarranted differences in care across the NCA. I think we need to say that right at the top if this is one of the main things we're doing. On page 10, when we talked about the 3 values, care, appreciate, inspire, we kind of said what they were, and then we said what they were not. And I'm, in terms of communicating, for me, I don't like telling people what not to do. I like to emphasize what I want them to do. So I thought we should be saying positive things like care, appreciate, is sorry, care is fully engaging and supporting people. Appreciate is being inclusive and saying thank you regularly. And inspire is welcoming other people's ideas and being bold and speaking out for what's right. We were saying those in the negative, and I just think be positive about what you want people to say. In the topic section on page 12 and 13, we've laid out what we mean by CLM, FSP, and digital strategy, but we haven't actually said what the communications piece is. So we haven't actually said a communication strategy. We've just said what CLM, FSP, and digital strategy is. So I think that needs to say, what is the role of comms in delivering CLM, in helping with FSP, and in delivering the digital strategy? And finally, on page 20, when we're looking at external media topics of interest, and we just had that R&I day, you know, we've got a research and innovation comms person who is not connected to your team, Julie, and that I don't understand. I kind of understand why that is in terms of funding, but I don't understand why that is. And you know, this doesn't mention research and innovation when we are a world-class research organisation. We saw that report. It was absolutely stunning. There should be something in the media every month on what this team is doing and internally. And I think, you know, there needs to be, whatever Claire Mooney is doing needs to be tied in with your, should be here in this comm strategy. And those were my 3 points.
Thank you, Suze. Let's go, Jeff, and then you go to Tuesday.
Thanks, Chair. 3 points. First of all, I really like the Ag People suggestion. We all miss what people really like in a work context. The more we can uncover that and build on that as an organisation, fully support that. I think that'll make a big difference, I think, going forward. So great with that. On topic 6, treatment to prevention, I think when we look at our strategy that we've just agreed with that resource yet to drive our public health work forward, there were 2 things driving that. One was treatment to prevention. The other was a really strong focus on health inequalities. And I would suggest if we could just tweak that to include health inequalities alongside prevention. Finally, on page 17, we talk about the channels of communication. And I'm not seeing there a real focus on shift to digital with all the proper safeguards for those that can't use digital. But nevertheless, although I know we're doing work on this, it's not high profile in my perception. And I think the more we continue to send letters to people, the more we look like an antiquated, out-of-touch organisation. We look inefficient. And I just welcome a stronger focus on that. And if that switch to digital being tracked through this plan. Thank you.
Yeah, thanks, Julie. I think on the two-way communication, yes, absolutely. The listening bit in the two-way bit probably doesn't come through quite loud enough. It still looks like broadcasting sort of messages as opposed to the listening bit, and how we do that better. So, so that point for me, I think the topic's fine, subject to what people have said. The only other thing that I think feels like an omission, and I couldn't see, I was furiously last night trying to read my papers, is governors and members as an FT. It talks about our stakeholders, our localities, all sorts of people, but nothing about our governors and membership.
Yeah, good point. In terms of kind of how we develop our communications with them, they are in the stakeholder plan, but they're not pulled out as under a specific heading like patient service users, our people. So yeah, very good.
Yeah, I'm doing exactly the same thing for council. Yeah, but we're working really hard to give them the voice and to be seen.
Understood. Thank you. Yeah.
Good.
Thank you, Julie. I've seen this before, and I say I really like it. I think the topics, because as you say, you know, we could communicate about everything and then become possibly white noise. I think pulling it into 7 key areas is really helpful, you know. And I think communications, like we talked about admin earlier, was one of those services that we all take for granted, but it's the lifeblood of the organisation, whether it's through comms or whether it's the interactions we have as individuals or our teams have amongst each other. And that two-way communication is really, really important. I think it's great to see the focus on freedom to speak up and really listening to colleagues in there. I think that's really important. I think for me, I do think it's really important that we articulate both sides of the coin in terms of the behaviours that live our values, because it sets a minimum standard and it gives all of us an opportunity to reflect, and B, it gives people an opportunity to have a conversation with a colleague to check in if they are behaving in a way that doesn't align with our values. I think there's probably a couple of little bits that I would comment on. One is the table on page 9 where you've aligned each of the topics to the NCA ambition. And when I read it last night, again, I looked at it and thought, oh, that almost feels like it's to an exclusion of everything else. Whereas actually, I think you could map it to every one of our ambition, and whether we frame that as the primary ambition or something like that. Because, for example, our values and behaviours connect through every single one of our ambitions. I mean, Jude's covered the point on governors as well, but I think that grid that you have further down the document around how we will communicate with those really key stakeholder groups, I think, again, really, really positive and really helpful to see it, because, again, I come back to, we take comms for granted, but this actually really sets out the amount of work that you as a very small team do deliver.
No, sorry.
Very much. So
Yeah, I think actually I've just got in my mind. It's not just a question of do with. Does the strategy talk about enough about how we would do and communicate difficult decisions? I wonder. The 2-year timeline is absolutely right, but I think the context and the change, there may also be thoughts about how we approaching the time when we start thinking about an overall vision refresh. So that, but you know, we know now, and it's a matter of public record, is that our full-time equivalents are likely to be less at a point in time. The journey to get there will be very, very difficult. You know, you take decisions around like car parking. And I just wonder whether somebody reading this in our organisation just might want us to see and describe a little bit more. How do the difficult, you know, to have a communications strategy that doesn't pay regard to the reality that we're going to be in, working through. And I don't think that, I looked at the FSP bit, I looked at the values bit, and I'm reflecting now that we might just need to just do a little bit further work to say, so how do we do the difficult? Or have we already got enough? The reason why I'm asking the question is because I'm not sure something jumps off the page at me to say, yeah, actually, when we're tackling that bit of our reality in there. So I'll be talented a little bit. It's just a one.
I'm sure I'm not answering, but I think it's a good answer. Jim and I have been talking about how when people make a decision, and it might be a difficult decision, for example, like car parking, how we kind of socialise that decision before we actually put pen to paper on the comms plan. And it's a brave thing to do because you want to set out your comms messages and get it all right for every audience, understandably. But there is for me something about us sort of trying to do things a little bit differently, in that we're not writing the comms plan and the comms messages to test how that feels. And maybe it's going a couple of steps back to how, you know, I used to do this stuff for Leeds City Council, it's really highly political, where, you know, we would actually write a document around what are the challenging things, what challenges are getting faced from the people that we're communicating with. So there is I agree with you. There's almost like it's a bit of a process to that we can, you know, the board would agree that, yeah, we'll make these decisions, but then there's always some discussion, 5-10 minute discussion on how's that going to feel when we communicate it. And I guess it's back to the point of, you know, why you make this, the basis of some of the decisions that you take. You know, if you're only going to make decisions based on how that impacts patients, that could have an impact on how our colleagues feel, for example. So I think we maybe do need a couple of steps back and to do that, because it has been quite challenging recently to get the comms right on some of this stuff, because, you know, we're sort of in a bit of a, oh, well, you know, I've got that bit right, and do we understand that bit when we've written the communication?
There's something what you just said, both of you, that is relatable to our lived experience as decision makers. But the context is we are living through transition, aren't we? We're making decisions based on some things we can control and some things we can't control. I think that reframing would be helpful, because what we have said is that we know we say today, in many times we're going to be making some difficult decisions, we're going to be having some difficult conversations. But what does that really mean? How does that translate into how it lands with our patients, our service users, our colleagues, and our community? I think it is something we definitely do. So if you could do some more, it would be great. Sorry, didn't see her hand. He's managed, what would you call it? Jimmy Cricket. Really, Jimmy. I'm still clothing. You stopped me. I have to come back to that. Tim, I'll bring you in now.
Yeah, really like the strategy, Duke. It's great. I just wondered, is there any more we need to focus on kind of an individual level? You know, across NCA, are we having the same communication principles at patient level? You know, asking, how do you want to be communicated with? This is how we will communicate with you. This is how your diagnosis, prognosis at each stage. We kind of leave that to clinical teams, individuals' decisions, and that's part of their professional life. But do we need to have a single NCA set of principles around that? I'm just kind of thinking, as a patient, you're just really concerned about how will I engage on my particular interaction with the hospital. You kind of might have an interest in the corporate piece, but it's very much just that individual personal kind of piece. And I wondered if there's any space in here for that.
But actually, you know, what you described in is where I actually think I would really love to be in 2 years' time. I think we've got some principles here that we kind of need to embed. And some of that is us talking to people about how they want to be communicated with. You know, we talked first point about shift to digital is a really good one. You know, we don't rely really on digital. You know, we do some socials, but in as an organisation, we're exploring some of the things that we could do to improve the experience. So I think that's kind of partly why I've said let's make this 2 years, because once we get this embedded and these principles and people understand, you know, how we can, this is a toolkit really for everyone to use, the basics of how we should communicate, and that it's endless, isn't it? There's no reason why then, especially as we move through clinical leadership model and the principles of that, let's do it, and let's roll it out. But I kind of feel like we've got to get to basics.
Yeah, sure.
So effectively, my period grew longer. Suzanne, sorry. We don't want board meetings to continue.
I'm not to carry on that. But Tim made a really important point, and I understand the timing of things, but going back to the comments before when we were talking about IPC and fundamentals, the basics of, you know, there's things that you would expect. I don't know what our communication strategies in terms of interactions with patients, but in some organisations, the first thing is, hello, my name is. And it's just the first thing of introducing yourself and giving somebody who may be in an anxious situation a little bit of ease. And for that to be repeated, whoever you interact with, and hello, my name is. It's as basic as it comes, isn't it, in terms of human interactions and how we'd like to treat people. So that it's just a really important point that if there was a way that we could represent that, I think it would be a shame to lose that.
I think that's I'm hoping that comes up through the focus group that we're going to, with patients and those users, because, if that's fundamentally what they're asking for, I think what we want you to introduce that, that's the number one piece of communication we want. Then, we need to react to that and actually, can all these bank channels as much as we like, but actually we're not meeting their need. So I think going to people, going and seeing, is really important. We'll do that quite quickly. I think we've also just got to be mindful that we can only do so many things. There is a team though. There's the Julie Cheese team as well, which we will work together on this, because it's not just the corporate communications function. It's everybody's job, isn't it? So we've been working with other teams on this, and Amy and Gertie's team to kind of bit like here and almost more like a batch.
Can I just ask you to consider the role of volunteers and executives?
Yes.
Yes, they are really important and relevant, and I think it should have. Yes. Right. Okay. We've had a very comprehensive discussion. I know you like to do. Thank you very much for getting the background and all the hard work you do. We have a plan which is absolutely right thing to do. Can I thank you and your team for the excellent work, exceptional work you do. 24-hour long question, we don't stop to you. Thank you very much. Okay, so we now move to agenda right over to the board recommendations. Agenda item 19 is the closed session for information, and therefore information going to be noted. Any other business? Board reflection, very good. It's very comprehensive, detailed, open and transparent and honest, and also along the way has some very helpful learning points which we'll take back. I want to go out Juliet for your professionalism and taking on board something which is not of your making. I just want to acknowledge that. Thank you. Okay, so data flex meeting, Wednesday, 7th. Yeah, 7th of May. July.
22nd of July.
Wednesday, July. And now I move to the resolution to exclude the press and public from the meeting at this point on the grounds that publicity of the matters being reviewed will be permitted to the public by reason of the confidential nature of business. The press and public are requested to use this point. May I thank everyone for their hard work saying all those things, accepting the causes that we've had. And I genuinely believe this has been very helpful, insightful, constructive session. Thank you for those joining online, and thank you to those who attended in person as members of the department. And that was the meeting, everybody.